I think I asked you the hardest question.
Sometimes patient preference. I offer them two solutions for different procedures, like a spinal cord stimulator implant, for example. I say, here's the way I could do it. You know, some of the older data said that lead might move a little more, whereas a neurosurgeon, or the spine surgeon might do a percutaneous, instead of percutaneous, do a laminectomy paddle, and it's less likely to move. But there are those risks, so I give them both options with that. With an SI joint fusion, they could do this lateral approach, limit your weight bearing a little bit, versus this, we could go straight to weight bearing. So I try and give them all the options and as unbiased as I can. You know, sometimes I have construction workers, these guys are hard laborers that the perc implant might not be the best option. They need that paddle, so I'll send off to my neurosurgical colleagues to implant with that paddle. If I see a fracture, insufficiency fracture, and through the sacrum plus that SI joint pain, I'm going to send it to somebody like Dr. Orfanos to do that lateral approach. It's just a better option when they have that fracture going through it. So there's no exact cookbook, but there is going to be certain case-by-case basis. Dr. Dorsey mentioned that interspinous process spacer. I had a patient with severe stenosis. You couldn't drop a number 2 pencil through it, which is also on Coumadin, Greenfield filter. Hasn't walked outside of her, ensuite bath in over a month. I'm worried she's going to get another PE and she's going to die if we don't do something. Send her off to a surgeon. He's like, I'm not touching that, and unfortunately, she's a friend of mine. So do I do it? Do I not do something and something bad happens? Do I do it? Luckily, these lower risk procedures, sometimes we could do under local without the general anesthesia, and it can be successful still. So risk mitigation and then case-by-case selectivity.
No, I think that's great common sense. A few years ago, your answer brings up something. A few years ago, Robert Levy, myself, Giancarlo Berlot, we'd be up here talking, and the only question was, is there a perk or paddle? We didn't have all these other procedures, right? So we're seeing this evolution. I think it's really great. Stephen Velasco, you're getting the last question. Then we're going to have a few minutes for everyone to make a summary point. I'm going to ask a hard question for everyone, the last thing. But here's the question. You're kind of a freak in a lot of ways. I mean that in a loving way. I mean, you're one of the neurosurgeons who really adopted to this right off the bat. Right out of your training, you became an advocate for minimally invasive things, and you became an advocate for all of us working together. What have you learned? Give me one thing you've learned the most important about this relationship in the last 10 years.
Yeah, that's a great question. And it's funny. I built a practice in academics for 10 years, and then I jumped ship and went into private practice. And I built the exact same model in private practice that I had in academics. And it's a model where you have true relationships between interventional pain and the surgeons. And I think it's funny, I think politics and turf wars make it more complicated than it has to be. It literally is just a sit-down, simple conversation to say, what are you okay with me doing? What am I okay with you doing? Like, what's the relationship you want to have? The last thing, if I was an interventional pain physician, for instance now with stimulators, for the most part now I don't do trials anymore. Even when I identify someone for a trial, I send them out to have the trial under the assumption that the permanent implant's coming back to me. If I was an interventional pain physician who did a trial and sent them out for a permanent implant and they came back with a 3-level fusion, I don't think that's a very good relationship to have. So, but the flip side also happens. Ramos said the same thing, right? Like, the surgeons send the patients to the interventional pain physicians and they don't ever come back, right? They're all in this black box of 3 epidurals a year and then just over and over again. And then they may have needed surgery to begin with and they never had it. So I think it's just a matter of literally just having an open discussion as soon as you want to start your practice. And the last example I can give is when I went into private practice and I joined a neurosurgery group, my goal was to bring all these procedures to the group, and we're in a surgery center together. And the very first procedure we tried to put in there, which was 2 of them, interspinous spacers and piled, both of them, my partners blocked like that. And I had to go out to dinner with them and literally have a conversation with them about this is what I'm bringing to the center. And we're going to start having more interventional pain options like this. So it was a simple conversation that changed everything.
Okay, so here's how we're going to finish this. And I think we have a research presentation at the very end. We're going to finish this starting with George, and we're going to go down the line and back up. So Stephen, you get the last answer. It's going to be painful for you because they're going to use all your good answers. So 10 years from now, we come back here. Hopefully, we're all still hanging out in Miami 10 years from now because we're never moving this meeting out of Miami. It's going to be here every year. I think we want to keep it here as where we're going to be. So here's the question for you. What excites you now, this currently just really new, that we don't know where it's going to go? What excites you about this space where this merger of spine surgery and interventional pain? What procedure or method do you think is going to be really prove to be really important? And we won't use brand names, but just give me a general idea.
Yeah, I think in my hands, the minimally invasive sacral arthrodesis has been the most exciting thing I've done in the last 6 months or so. I've had some really good results. It's given me another tool when these patients come in and help me differentiate their problems, where a lot of times I stimulated those patients assuming that this was just a failed back when it was truly just a sacroiliac joint pain. And so I think the data will really pan out that this is a very advantageous procedure.
Very nice. Michael?
I'm hopeful and excited that in 10, 15 years we won't be having discussions about who should be doing fusions, and that we will have regenerative medicine techniques that prevent us from getting to the point where we're even thinking about fusions. So I'm really hoping that some of the disc regeneration comes to fruition finally, and we can prevent people from getting to the point where they're needing our assistance on fusions.
And so am I. I've been waiting on that for a long time. I hope we get there. There we go.
I think if we're really looking at it's the importance of innovation and education, and getting the access to all these procedures, the awareness of structural stability, and how to diagnose and evaluate candidacy early in the education of the practitioners who are coming out of the next decade.
Ramo?
Well, Michael took my answer, but I think the really interesting thing going forward is how minimally invasive fusions are actually becoming. And really, there's a lot in interventional pain physicians' wheelhouse that is advantageous as far as using fluoro. The big question is efficacy, dealing with complications, but I think as technology gets smaller and smaller, that's actually possible. And I'm not saying I'm going to do it, but I think 10 years from now, we're going to be talking about that possibility and how we figure out who's doing it and what's good for the patient.
Very good. Chris?
Obviously, it's been an exciting time in the interventional spine space, the last 3 to 5 years, a lot of fun stuff. But in the next 10 to 15, if we could potentially combine a lot of these technologies, expandable therapies that go in minimally invasive along with these interspinous fusion devices having the spike nature of it, where we could go in percutaneously into a disc, elevate it up to alleviate that pressure, open up a foramen, plus still have some motion preservation there. So we have disc height restoration in a mechanical sense, opening up the foramen, the lateral recess, the central canal itself, but still having motion preservation. That potentially could happen in the next 10, 15 years.
No, I think that's pretty cool. I hope you come up with that. John?
Spine surgery is such a dynamic field. I think that's what's been so exciting for me, being a part of this and growing up in it now, is just how much it's changed. Even in the last, 10, 15, 20 years, massive change in spine surgery, how we do things, what we understand about the spine as a biomechanical organ. And I think that we will still continue to learn more. Maybe, a pedicle screw will be obsolete. Maybe, more of our minimally invasive techniques will take hold. And I hope as a neurosurgeon, that, our societies also will kind of collaborate and maybe, so we don't just be statues and let progress pass us by, but actually continue to innovate and also make this progress, because it will happen. That has been what spine is, and that's what's so exciting about it.
I love that. I love that answer. I think collaboration between the societies would be really nice, And Stephen, you get the last word.
All right, so I'm going to take the politically correct way and say I'm not going to choose one procedure. I'm going to choose all of it, in the sense that, minimally invasiveness is not a fad. It's not going away. And as all this technology continues to evolve, you have to evolve your practice and evolve the algorithm of how you take care of these patients. And I kind of said it before in one of the other panels, like if you're not on the train, you're getting left behind. It's really going to be the case now, because you're being forced to learn all these new therapies if you want to keep up with taking care of patients.
Okay, that's it. But we'll go back over to Dawood for the last 20 minutes. Dawood.
Don't leave. This is one of the most exciting sessions here. I'm back up. Guess who's back? Back again. So as Dawood told us earlier, these breaking research sessions were hand-picked studies that are relevant to our audience and relevant for our patients. They were picked by members of the society who have no conflicts of interest, and this is one of the reasons why we get excited about these presentations, because they're few and far in between during our sessions. So with that, let's go to the first one, which Dr. Syed is going to present for us, the multicenter real-world review of long-term efficacy of a posterior sacroiliac fusion device. Dr. Syed?
Thank you, Kaz. So I'm going to be presenting, as Dr. Amerdelfin said, our multi-center real-world review of the long-term efficacy of a novel posterior sacroiliac fusion device. So the background is that we all know sacroiliac joint pain causes low back pain that's difficult to treat, and that open and minimally invasive approaches have been used to treat sacroiliitis over the past 2 years. What really has been limited up to this point is evidence for the posterior approach. So here we'll talk about a novel, minimally invasive posterior SI joint fusion technique using a posteriorly placed transfixing device within a single point around the S1, S2 foramen, or the mid-segment of the SI joint, for current, and we'll evaluate the current efficacy and safety data for this novel procedure. So the objectives were to review multi-center retrospective outcomes that were greater than 12 months and do a subset analysis on patients with or without prior lumbar fusion to see if lumbar fusion is something that shows a better efficacy than non-fusion patients. The methods, so patients with sacroiliitis refractory to conservative care with short-term benefit from diagnostic local SI joint injections received the MIS fusion approach with allograft, and they were included from 3 different centers, academic and private. A numeric rating scales at baseline, pre-procedure, and at the most recent follow-up were included, as well as some functional outcomes. So here's just kind of a working timeline. So we had about 110 patients that were initially included. We were able to find 50 patients at this point in time that had at least 12-month outcome or greater. And again, all these patients had successfully completed a posterior SI joint fusion procedure. In our cohort, 24 patients had had a previous prior lumbar had not had lumbar surgery or lumbar fusion, and 17 of the patient had prior lumbar fusions. The average NRS for the subset was around 6.85 at baseline and about 2.86 at the last follow-up. And we'll talk a little bit more about the data here. So here's the surgical technique, again, using a single point of fixation, using a cortical allograft with a graft window that was unique to it, and that's what's novel about this approach, and aiming for that mid part of the joint. So here's our results. You can see at baseline the overall pain scores were around a 7.4 in patients with no surgery and about 6.85 in patients with a history of lumbar surgery. So the average VAS was around, or NRS was around 7.06. At the last follow-up visit, you can see an average numerical score of about 3.09, and patient reported percent relief was around 66.5% overall. And I'll add that the average follow-up was greater than 12 months, but in this cohort, the average follow-up in this was around 620 days, so almost really 2-year data on this subset of patients. So again, in summary, in our multi-center real-world study of 50 patients, we show that single-point fusion in a posterior approach allows for the least amount of tissue disruption in this technique. No patients that were in this cohort received any further SI joint intervention, so no other techniques were needed to manage their pain. Again, we show that this was also a very safe and effective approach, no major complications or adverse events. And our 620-day follow-up is really the longest average follow-up that's been reported for any of the posterior SI joint fusion systems. Thank you very much.
Dr. Syed, thank you so much. That was a great presentation. Very encouraging to see this sort of posterior approach, sacroiliac joint fusion, to evolving with the kind of evidence that you've been collecting. I have a practical question for you. I know that you're doing a lot of these fusions in your center. I see a lot of bleeding that happens, and I'm managing it by putting some gel foam and everything in there. How are you doing that? How much? What do you do when you have bleeders in a side joint fusion?
So just to point out in this study, so no significant bleeding events were noted in our cohort, so no one really required a blood transfusion or any type of other further management. I think bleeding is expected. I kind of tell my patients it's actually something that's a good part. We need that kind of that blood and all that stuff to promote an arthrodesis. So we just kind of tell them, I send them home with just another set of dressings, so they're usually going to kind of go through those dressings, sometimes in the recovery area. It's a good thing that actually happens. Obviously we don't want a hematoma or those types of things, but again, in our cohort, no significant hematomas or blood transfusions or anything were needed. So there is some bleeding, but nothing that really needs medical intervention.
Perfect. Thanks so much.
Thank you.
So the next session is Dr. Falowski presenting the long-term data from the TRIUMPH study, which is a burst study spinal cord stimulator. So Dr. Falowski, please.
All right. Well, thank you everyone for staying on what stands in between you and lunch. So we'll get you there. So I'm going to present the TRIUMPH study. So the TRIUMPH study is a prospective study, 2-year data, first of its kind actually in spinal cord stimulation, where patients in the real world and for real world reasons to have a spinal cord stimulator implanted were followed for 2 years. But also what makes it very unique as a study is instead of just using an endpoint of pain scores, they actually followed endpoints of functional outcomes, which is something that I think we need to do more of in our space. I think you're going to see a paradigm shift over the next couple of years, especially with spinal cord stimulation, that we're no longer just going to be following pain scores, which can become very subjective. We're actually going to start following functional outcomes. Are these patients doing better? Are they doing more activity? Do they feel better about their pain? So these are my disclosures. So just a little background on the TRIUMPH study and what it looked at. It looked at the burst DR waveform, which is a proprietary 5-pulse sequence that's basically physiologic. It was originally founded by Dr. DeRitter, who was doing work on tinnitus, and he realized that the reason people had tinnitus is because they had abnormal burst firing in their brain, basically relaying through the thalamus. So that's how eventually the burst waveform was used for spinal cord stimulation to try to treat pain, because it relays through the thalamus. What they actually saw over time was this unique mechanism of how it actually works. So traditional spinal cord stim works on the lateral pathways. The best way to think about the lateral pathways is we generate tingling, right? So I used to tell my patients that, when you wake up in the middle of the night and you bump your shin, what do? You reach down and you rub it, and the pain goes away. It's not because the pain went away, it's because your sensory cortex starts thinking about the rubbing. That's your lateral pathways. That's how spinal cord stim historically has always worked. But there's also the medial pathways, which go to the frontal lobes of the brain, which is the part of the brain that looks at how you think about pain. How do you ruminate about your pain? It's the difference between why you can give Granny 50% pain relief and she goes to the mall with her grandkids. You give someone else 50% pain relief and they tell you they're bedridden. So there's multiple studies looking at EEG testing, as well as the one in 2016 with Dr. Yearwood and myself, where we did PET scan imaging to show we could light up the frontal lobes of the brain with the burst DR waveform. So this is a multi-center single-arm study following patients from around the world, so US, Canada, and Europe, 128 subjects basically who made it to the 2-year mark that we could have data for. And this was basically looking at real-world indications, so not inclusion and exclusion criteria. That is not what we're used to in the real world. This is any reason you were implanting the patient for that you got it approved in your practice. And then we followed them throughout for up to 2 years, looking at functional outcomes as well as pain scores. So here's the results of the functional outcomes. I think this is pretty impressive because what it shows is that once you hit even the outcomes at 6 months, it held true in all the patients out to 2 years. One of the ones I like to point out is the pain catastrophizing. Pain catastrophizing is very well known for going through the prefrontal cortex. This is how you think about your pain. This is where you find your pain to be debilitating or not debilitating. When you look at all these psychometric measures that are up here, they all reached what we call the MCID, the minimal clinical important difference that's needed to actually be considered a change that the patient's going to feel. So change in depression, change in their pain catastrophizing. In fact, in the pain catastrophizing improvements there, they actually reached the standard population. So when I say standard population, I mean the patients who are not suffering from pain, what they would look at as pain catastrophizing, that's where these patients actually reached. So this was looking at the NRS pain scores and the outcomes that they had. Same thing again, once you hit 6 months, you were gonna make it to the 2-year mark. What's interesting is that we looked at very different things in this study, functional outcomes, but we also looked at the pain scores. But we didn't just look at the pain score from the subjective number that the patient gave us. We also looked at asking them, what's your % pain relief? And how many people in their practice, you say to your patient, how much pain relief you have? They say 80%. My pain score went from an 8 to a 6. Right? It happens all the time. We actually saw the same thing in this study. If you actually look at the average pain relief, it was anywhere between 60 and 80%, but the change in pain score was about 50%. But we looked at both of those actually separately. But then we looked at patient satisfaction. It was greater than 80% in satisfaction of whether you would have the procedure done and were you happy with the procedure. Then we looked at quality of life. And basically the EQ5D, what they actually showed was that it got within 1 standard deviation of the normal population, which means we were returning people who were severely disabled to basically being almost close to just a normal person who doesn't have chronic pain in the population. And then you can look at other things like the physical activity, pain, discomfort, care, and what you can see significant improvements that came out to 2 years. So I think, just in conclusion, this is one of the first times we've actually looked at real-world outcomes out to 2 years, but focused on actual functional outcomes, psychometric measures. And I think that's what we're going to see more of in our space, is looking at true functional outcomes and those changes.
Excellent. Thank you so much, Dr. Falowski. That was awesome. One question, as an expert in this field and somebody who's been doing burst stimulation for a lot of patients on a long-term basis, in this particular study, did you use continuous burst, or was pulse dosing burst also used in some of the patients who needed it?
Yeah, that's a great question. So for those who are aware, so the burst therapy can actually be cycled. And there's different levels of cycling, from 30 seconds on and 1.5 minutes off to 30 seconds on and 6 minutes off. And there's also what they call continuous dosing, which the original studies that were done on burst had continuous, meaning keeping it on all the time. In this study, all the patients fell between somewhere in that window of 1.5 minutes off to 6 minutes off, and it was based on where they got the best pain relief.
Excellent. Thank you.
You're welcome.
So I believe that it's the lunch at this point, right? So who's sponsoring the lunch? Go ahead.
So if everyone can now head on down, Relievant will be hosting our lunch. It is going to be in the Poinciana room starting at 12:30. So you got a little time to take a restroom break and meet us down there for lunch. Thank you.
All right, we want to try to get started on time. I know everybody's coming back from lunch. Dawood is a little bit delayed. He's going to go out and get a bite to eat. He had a meeting, so I'm going to kickstart our afternoon. It's 1 after. We're going to get started at 1:35 with our regenerative medicine for low back disorders, and Dr. Natalie Strand is going to moderate that. So we're waiting for everybody to come in for us to get started. There they are, the professors.
Somebody needs to sit in front.
Do you want to? Who wants to sit on the couch next to me? It's not a threat.
Me.
Thank you all so much. Natalie, the podium is yours.
I'll give it just another minute or two to let the crowd come in as we have this panel of experts that I'm so excited to learn from and hear from. Good to see you.
And they're not just experts, they're supermodels as well.
Yes, experts and supermodels.
That's right.
All right, it's 1:32. I'll wait till 1:33 just to let people come in.
Sounds good.
Thanks for, Dr. Pacious has arrived, so I think we can get started. All right, so I'm Natalie Strand. I'm going to be the moderator for this session. We're going to be talking about evidence for regenerative medicine for low back disorders. I know I opened the day saying that radiofrequency ablation was indeed sexy, but there is nothing sexier in our space than regenerative medicine. Patients are attracted to it, providers are attracted to it, so I think this is a really important session to really go over the evidence. So we're going to cover the appropriate patient selection, different regenerative therapies that are available, the regulations and the ethics of this, who should get it, when should they get it, and we're going to go over the evidence, including some really late-breaking evidence. So I'm really excited. I'm going to start with Dr. Hunter. I just wanted to ask you to review briefly PRP, bone marrow aspiration, concentrate, and sort of the nuts and bolts of what people should know about regenerative therapies like those.
So I think the evidence for PRP for intradiscal injections, it's been good, it's been moderate. But I think that for people that want to use it just as a standalone, there wouldn't be companies like Vivex and Mesoblast and Dysgenics putting hundreds of millions of dollars into studying if it was just as simple as taking just blood out. So there, as we're learning, there's with discogenic pain, this is something that's been the white whale for our field for decades. So since when I came in and this man trained me, it's been something that there's been no one answer. It was IDET, then it was biacuoplasty, and that was some other some really great things to do with it, but it's just I don't think we have a full grasp of it yet. So as the evidence continues to evolve, we're going to find out that I think stem cell therapy is going to be where it ultimately is, and then we're going to depend on some of these players to create these really nice cells that are committed to doing what they have to do, and then this nice scaffolding and these the vehicles that will go in there. But it's a complex field. It's not just going to be something as simple as just sticking a needle in someone's back and just injecting whatever it is. It's really going to be a very one size for one therapy thing only.
So I have a follow-up question to that. Do you see this as the future of our specialty, or how do you see this integrating into pain medicine at large in the next 5 to 10 years?
Well, I hope it is. I think that the Occam's razor says the simplest solution is usually the most correct one. So if it's degenerating, regenerate it. So I've been doing stem cell research for the better part of 25 years, and there's some things that just doesn't fix itself, whether it be neurons or whether it be the spinal cord, whether it be the nigrostriatal pathway for someone with Parkinson's disease or a disc. So ultimately, this is something that I think will fit into everyone's practice, and you're going to see discograms come back. So it's really just as simple as sticking a needle in there and fixing it. I think everyone will probably adopt that to their practice.
Thank you. Dr. Dewan, I know that your practice is focused on intradiscal injections of BMAC, stem cells, PRP for musculoskeletal pain. Can you talk a little bit about disc injections, the evidence, patient selection, whether or not you need to do a discogram? What do people need to know about that?
So lately I have been doing a lot of bone marrow stem cells for intradiscal injections. And there is a fairly good evidence in the literature. One study comes to my mind is Kenneth Patton's study, who is a 5-year follow-up, just came out 2 years ago. And it studies about 26 patients. All those patients were in the list for surgery, either disc replacement or the fusion. And they all received 2 cc of the bone marrow concentration. And all these patients were followed for 5 years. Out of 26, only 6 patients went for surgery, and 20 patients did very, very well after 5 years. So there is a really good evidence. Now, this study comes from an orthopedic surgeon, it's not coming from the pain management group. So it's nice to really see the results like this. So there is an evidence. It really works very, very well. Autologous cells. One thing that we have to realize that there is a symptomatic improvement and there is a structural improvement. Now, if the symptomatic is right away, within a few weeks, you will see patient will start feeling better. However, if you do a MRI or any kind of studies, that you will not find much because the degeneration has taken 3 decades to happen, and you don't expect to reverse within a few weeks or a few months. So it does take some time. In this Kenneth Patton's study, there was a 40% patient actually did show 1 grade improvement in the Fearman's classification. So there are some very good evidence for the bone marrow concentration for intradiscal injections.
Thank you. Can you talk a little bit about your patient selection? What factors are you looking at to try to maximize successful outcomes?
So this is very tricky question in a way, that because right now patients come to us when everything else has failed. Not necessarily they are the ideal candidate for the bone marrow or PRP injections. But the studies have shown that if you have the count more than 200 million or a CD4 more than 2 million has a better outcome. And those who were younger and their CFU use were more than 2,500, they have better outcome. So I would say sooner the better. Once the patient has symptomatic degenerative disease, I think we should consider it. But again, because it's a cash payment, insurance doesn't cover, we have to be very, very careful to talk to your patient, make sure that you are talking the science and the evidence and not just that you are interested in making money.
Thank you. Dr. Beal, you're up next in the hot seat. You've recently had an abstract accepted for your recent research. Could you go over the relevant findings of that research and what we need to know?
Yeah, sure. In patient selection, I'm going to tag team a little bit with Dr. Gaiwan on that. So the most recently accepted paper was called the VAST trial, and this is viable allograft and mixed with 6 million mesenchymal stem cells, 0.75 cc's of micronized allograft down to 300 microns of disc. So the patient selection for this was something that we kind of put together. It's an algorithm, physical examination, clinical signs. I went over the physical exam earlier about sustained hip flexion, and people, you know who they are, can't sit, can't drive, pain with bending at the waist, pain with bending forward, anything with weights, pain with brushing teeth, shaving, leaning over a sink. These are people that really are absolutely classic candidates for this. And combine this with MRI selection, modified Fearman grades 3 through 6. 1 or 2 are normal, 7 or 8 are degenerated, 8 is disc dust. And then we can choose these patients based on discography or based on just clinical selection. And what should you do? Well, let me give you a very definitive, I don't know. Because in my patients, and I enrolled 50 plus patients in this trial, I do discography on every single patient. You compare this cohort to, say, Steve Gershon's patients who enrolled mid-30s, about 35 patients, did it only by clinical examination and MRI, similar to what we do for BVN ablation. No difference. So, because I'm, jaded and bitter and set in my ways and old, I'm going to continue to do disc injections because I think it's the right thing to do. But patient selection, you can either do it that way or you can do it by imaging plus clinical characteristics. The final synthesis of this 218 patient triple arm randomized control trial got up to VAS improvements of 45, ODI improvements of 37. It's almost 2 categories. And so this has been accepted into Pain Physician, and I expected it to be published last month, so hopefully that means this month or next issue, and it should be impending, that data, that research.
Thank you. The next question is for Dr. Kolodny. I know you're very experienced, but I'm going to ask you to peel it back to someone who's just beginning their regenerative practice. If you have any information to share on the nuts and bolts, and also if you could talk about the safety of doing this kind of intervention for patients.
Sure. We're talking about low back disorders, but we're really confining most of our remarks to the disc. So let me just say that, there is literature, not a lot, but there is evidence for use of this sort of treatment for facets and SI joint as well. But let's go back to the disc. I think it is for an interventionalist a great entry into regenerative medicine. There's reasonably good evidence supporting the safety and some evidence reporting the efficacy of using biologics, autologous biologics, that is, for the treatment of discogenic low back pain, both PRP and BMAC. My practice is largely an autologous practice. We do a little bit of allogenic work, but it's only as part of clinical trials. So I think the easiest way to start is to start by finding perfect patients. Patient selection, of course, is paramount. And then considering the use of platelet-rich plasma. It's much easier to obtain. It's cheap. You're unlikely to cause any harm by injecting a needle in the disc. Of course, there's the Carnegie study from about 10 years ago, a cohort of patients who purportedly developed some degenerative discogenic changes at a higher rate on the discs that were treated with discography, but I think we've debunked that. The incidence of discitis is very, very low. Geyer, 2002, 0.14% per disc, and it's probably lower than that. Incidence of disc herniation in the last 15 to 20 years. Injecting a disc, there's only about 5 or 6 cases in the world literature of acute disc herniation from injection of the disc, and just don't overpressurize the disc. That's one little pearl that I would suggest to you, whether you're injecting PRP or BMAC. But the use of BMAC or PRP is easier entry point. There's some good data for PRP out of HHS. Dr. Lutz has studied a group of patients that had a single injection of PRP at the time of discography, and some of those patients have been followed now for 5 to 9 years, and that's been reported, and the results are actually pretty good. It's amazing to think that a single injection of PRP at the time of discography would have such a longevity effect and durable effect on the disc.
Thank you. That's a great answer. Dr. Davis, I know you're doing a lot of cutting-edge research. I was wondering if you could share some of that recent research and what we need to know about the cutting-edge therapies that are coming to market in this space for back pain.
I thought I was doing cutting-edge research about 15 years ago when we did our first intradiscal study, and we still have a raw edge that we're cutting through because we still don't have anything, on market. And I want to make that point very clearly. Regardless of all the stuff we've done to date, there is still no intradiscal FDA-approved thing on market right now. So anything we're talking about, either it's still in studies, or it is an off-label, or it's an autologous type of use, like Dr. Kolodny was just talking about. But so one of the companies that we wrapped up, I think about a year ago, Discgenics. It was an intradiscal injection study, 60 people we enrolled. It is a progenitor cell, so it's not a stem cell. It's kind of a little further along the development line. That looks like a very promising technology. They also have another arm of it over in Japan where there's 38 enrolled. And so I think that some of that data should be coming to light maybe near the end of the year. They're looking for their next phase to start end of 2022. The study that Doug had mentioned with the the micronized nucleus pulposus with cadaveric cells, that product has gotten a little bit derailed from some of the FDA guidelines that have recently come about, and so they've had to remove the cells from that product, and now we're going to be studying nucleus pulposus alone as an intradiscal injection. So that's something to look forward to. There's another company, Remidisc. What's the Spine Biopharma? Yeah, Spine Biopharma. Oh, yeah, sorry. I'm unbiased on any of these names, by the way. It's just, that one more reduces an inflammatory response inside the disc. And so looking forward to see some outcomes of that. But, you know, the reality is we've been grinding away at this for over 15 years and, I don't know, like 8 to 10 different studies. And we've made some forward progress. We've certainly learned a lot. We've learned that saline is absolutely not a placebo, regardless of what anybody says, because the responder rate that we see across all of these studies well exceeds anything that you would ever think placebo was. I have a lot of theories on that. I think it's a lavage of the disc. I think it probably normalizes the pH, decreases some of the inflammatory types of activities, and so obviously you're going to get some sort of positive response. If you have a dirty wound and you wash it out with saline, it's going to heal a little faster. So, you know, that's something we've been fighting against on all these different studies we've been doing as saline is our control. Now we're trying to move towards sham as being a control because my belief is that will show us a greater delta off the baseline pain when you have an active and then your control is a sham or just a needle going through the skin.
Thank you.
Did that answer?
You did a fantastic job, Dr. Davis. So lastly, but definitely not least, Dr. Emmer-Delfin, before I ask you about your latest studies, which I'm definitely going to do, I'd like to ask you to expand a little bit on what Dr. Davis just mentioned with the FDA restrictions and regulations. I know this is a very complicated question, but again, for people starting this practice, what do they absolutely need to know about the FDA so that they don't do any missteps?
Yeah, that's a great question. And, you know, in a way, the FDA is also evolving and trying to figure out how to deal with a tsunami of new evidence that's coming to them with regenerative medicine. And there are so many different companies in it. But what the FDA is looking for at this point, just like any other frontier, they're looking for large patient, multi-center, randomized controlled trials that are somewhat sham controlled to some extent. And once those are done, then they can evaluate those studies to be able to see if this particular product can come to market in the United States. In fact, we just completed a study as such. So we did a phase 2 study with a manufacturer out of Australia. Some of us were involved in that study, and we just published the 36-month results in single-level lumbar disc without radiculopathy, where we injected saline, hyaluronic acid, the stem cells with hyaluronic acid at 6 million and 18 million. And the 6 million group showed a significant reduction in their pain, a significant increase in their function, a reduction in the use of interventional procedures, and it was really quite promising, and that was designed as a safety study with 100 patients. A randomized controlled trial of a much larger patient population has now been completed. The entire data has not been released yet, although some of us have had the pleasure of seeing that data set. But the press release that they had shows how the patients were able to get significant improvement in their low back pain and improvement in their function over placebo. But those kind of randomized controlled trials in hundreds of patients that are sham controlled and multi-center are necessary for us to be able to move forward and get the kind of regulatory approval for us to be able to use it. But I think that the take-home message from this is that all of this is really new. We're wrapping our head around it. We're trying to figure out whether we can at least slow down the progression of disease and in some cases maybe even reverse that to some extent. But all of that remains to be seen. It's incredibly promising. Keep your ear to the ground, come to these meetings, and read the publications. The 36-month publication is in Spine. If you want a reprint, just email me, I'll send it to you. And Dr. Kolodny said it best. You know, patient selection is absolutely key in everything, and this is no exception.
I'm glad you ended with that. I'm going to ask you one more question, just on the ethical use of this. I mean, for a lot of people, this is a cash practice. There's a lot of excitement about it. It's cutting edge. The tsunami of data is arriving. So what advice do you have, again, on the ethical side, You talked about the importance of patient selection. Are there any other pearls that you have to make sure that the excitement doesn't overwhelm our ethical compass?
Yeah, absolutely. I think that's a really valid question, especially since everything we do at this point with stem cells is only on a cash pay basis. I think that the patients really need to be given a candid representation of what it is that we have, the level of evidence that we have with these things, and what's available to them outside of that. You know, I think, you know, some people are very comfortable with the price point that something like this comes into, but at the end of the day, from an ethical standpoint, in order for the physician to be able to look at himself or herself in the mirror in the morning, they need to be able to tell the patient from the ground up what it is that they need. And the patient selection, in my opinion, Dr. Beal is right, a discogram is incredibly important as the selection process for those patients, so patients are not being treated frivolously with this. I think Tim Davis has a couple of points about this too. I know, I can hear the wheels turning in his head.
So yeah, you don't be blinded by the dollars. You don't overpromise. I even stay away from talking about any of these procedures as a stem cell procedure. When I'm doing a bone marrow aspirate concentrate, that's exactly what I call it. They ask, are there stem cells? Yes, there are stem cells in there. Do you know how many? No, they decrease with age. You know, the concentration decreases with age. I think that we can, if you start marketing too much online about stem cells, regenerative medicine, these terms are being bastardized to a certain extent. And there are some, you know, gray area players out there that are making a lot of claims. You gotta, I mean, you really have to just watch what you say about what kind of claims you make. If you want to cite some sort of publication and have that as a reference on your website and say, these are things we've seen, but I still will always back that up with, we still don't have a large-scale randomized clinical trial. And oftentimes people say, I don't care, it's fine. And so you've educated them. But please really be careful about what you say online, what you say to your clientele. It can and will come back and bite you. So just play it straight.
Thank you. That was excellent. Thank you all for being on this panel. It was awesome.
Excellent. Thank you, everybody. I'm not as handsome as Dr. Dawood Syed, but I'm his replacement at this point since he's eating lunch. So it's my pleasure to invite the next panel up here, the Evidence for PRP panel in musculoskeletal disorders. Where's Kate? Oh, there you are. All right, excellent. Kate, the floor is yours.
Hello, everyone. So I think we have Dr. Ha coming up. Great. And we have Dr. Ranson, so everybody's here? Great. So just to continue with talking about PRP, we're going to focus more now on musculoskeletal disorders. We've already gone over some spine. Now, I did want to talk about the ideal patient for these particular cases in your practices and just kind of go down the line. So Dr. Hunter, we could start with you. Who's the ideal patient?
So I think what people don't realize is that there is actually a ton of evidence for PRP. There's a lot of level 1 data. There's a ton of level 1 data for it. I think where people, just to kind of take a step back, where people don't really realize where PRP is useful is that people either think it doesn't work at all or they think it just works on everything and it's just pixie dust and you can put it like on anything. But the bulk of the evidence is there for things like a tennis elbow, jumper's knee, you know, Achilles tendon, things of those nature will work phenomenally for these patients. But it's, you know, one of those, like I learned from Tim Davis, it's not one of these things where you can just, you know, put it in and that's it. So sometimes it takes 1 or 2 treatments, but it works very, very well. For osteoarthritis in the knee, for example, there's, I think there's like 13 publications out there that show that it's at least as good, if not better, than hyaluronic acid. So for a patient that doesn't want to get a series of 4 or 5 injections, they can pay and just get 1 PRP injection. So it really does work. But the evidence is there. So I would encourage people who want to use it in their practice to actually go out and read the evidence to find which patients are there. You know, just find one thing, like one specific indication that you're going to do, and then do that first and do that a ton, and then get comfortable with it. But it does, I mean, like I said, people don't really realize like the bulk of evidence that there is for it.
Excellent. If we could continue down the line, what is your experience with this in your practice?
So exactly, I totally agree with Corey. There is tons of evidence out there. However, if the condition is very advanced, advanced osteoarthritis of knee, for example, then your outcome may not be as good as you would see in the first or second degree degeneration. Having said that, we do have one issue with all these studies, and is that there is no standardization. If everybody uses a different product, everybody uses a different kit, and everybody, because of that, you really don't know how many cells you are using. It's 5 times the peripheral blood, or 2 times the peripheral blood, or it's just the PRP, it's a protein. So there are so many variables that we have. So to really get some good understanding of the outcome of the study is very difficult. For example, ATM. If you really use the PRP, platelet-rich plasma, it hardly has any A2M. And as you all know, A2M is very, very important because it's a broad-spectrum protease inhibitor, and proteases causes the cartilage degradation. So it's very important. So then there are different products where there is no actually a Buffy cord. It's just the separation from plasma from RBCs, and it has a less number of platelets, but then you have more scaffolding proteins, fibronectin, fibrinogen, and things like that. So because of that, I think it's very difficult for us to really, very precisely to learn from the studies out there.
Thank you.
So I think this kind of fits into the practice in a stepwise fashion. So some of the easy things for me are Achilles tendinopathy, jumper's knee. You're not going to inject the common extensor tendon with steroids because you're predisposed to rupture. These are all easy PRP things. And as Dr. Hunter mentioned, there's lots of data in this in joints in the knee. And as Dr. Kolodny mentioned, there's the Lutz paper. Anu Navani had a great paper on the use into the intervertebral disc. And as I just wrote a chapter on biologics for intervertebral disc, there's a lot of PRP data, a lot more than I thought there was. When you actually start sifting through the literature, not only is the PRP data abundant, the results are pretty darn good. And it's kind of similar to the Wu meta-analysis for the other intradiscal cellular therapies. So the heterogeneity of it all makes it really difficult to know what to do because, quote Dr. Kolodny again, is for use of stuff, biologics in the disc. I mean, he had a slide a few years back that I saw. It said the intervertebral disc, where all great therapies go to die. And it just, I mean, it's so true, right? And so we started putting PRP in the disc. It works, but it's a little bit heterogeneous. What do we do? Well, it's a stepwise fashion, and I think that's okay because Dr. Davis here mentioned the product called Remidisc. It's a 7-amino acid anti-inflammatory amino acid anti-inflammatory peptide that works on the SMAD pathway. So, you would probably use that before you use something more expensive like cellular therapy. And PRP, it kind of, in my mind, fits into that niche. And the more evidence we can have, the better, and the more well-founded we can be for using it.
What was the question?
So we're still talking about who is the ideal patient.
Right. Well, I don't want to just restate I would say I agree with everything these guys have said. In practice, it's easy to do the tendons, the plantar fasciitis. It's any of those tissues that don't have great blood supplies to begin with. And the way I describe it to clientele coming in is, they have a chronic inflammatory process, right? That's the tendinitis. And so it's just not kick-started that healing cascade. And so the way I describe PRP to them is we are purposely going to insult that tissue again, and we're going to provide it with a concentration of platelets that it normally does not see during the initial insult. And so they kind of get that. And then if you compare it to other mechanisms of healing that they're very familiar with, like cutting their skin or breaking a bone, everybody could plot out a timeline for you, and you say, that's what we're trying to apply to these tissues that now don't really have good blood flow. So it's a great way to kind of put it in perspective for your clientele. I think that PRP is a great entry point for regenerative medicine because from a price point standpoint, whether depending on what zip code you're in, whether you're charging $400 for it or $1,000 for it, that is within reach for a lot of people. And especially if you're looking at injecting on a tendon, look, all you gotta do is have one tendon rupture after a steroid injection, and you never want that to happen again, right? So you have the opportunity and the option to do something with PRP that can be more healing and beneficial, and I think it fits very, very well. When it comes to intra-articular, my belief on the intra-articular side of things is if you can really localize where the injury is, and this is something that Chris Centeno was very keen on in the early stages, was making sure that anybody he was training really understood how to use ultrasound, how to do ultrasound-guided injections in the joints, and understand what structure you're actually coming in contact with. If you want to aim at the ACL, you don't just put it into the joint. Put it right where the ACL is partially torn. If you want to aim for a meniscus, get it into the meniscus area, because putting it just throughout the entire joint may do one thing, but if you get it directly at that point of injury, you potentially could do a whole other thing.
Yeah, I think I'll second that thought. It's hard to answer this question when we've got a lot of great comments already. I think in terms of the ideal patient for PRP, one of the things that I'd want to emphasize is we're so used to offering corticosteroid injections to our patients. And if we look at the data, what is, I think, great for PRP is that we see sustained long-term benefits. There was a recent systematic analysis of systematic reviews, so kind of like a mega systematic review of lateral epicondylitis and PRP. And we see some sustained benefits over 8 weeks. And the corticosteroids, they have a short-term effect. And I think we should rethink our pathway in terms of what are we offering for our patients. You know, they may be comfortable with the steroid pathway, we're comfortable with that, but perhaps we need to bring PRP to the forefront. And the other thing about the heterogeneity in the clinical trials is also image guidance. So I think this was a point that was just brought up is how are we doing these injections? Are we not getting the results in our randomized controlled trials because they are blinded injections, and perhaps we would be more precise with our targets if we use our ultrasound guidance?
Thanks.
I would certainly agree with all the comments. I think the entry point would be tendons. It's easy to do, but everything we do with regenerative products has to be done image guided. It cannot be done blind. Even if it's a simple extensor tendon injection, you really owe it to yourself and your patient to use ultrasound. That's an easy entry point. Generally speaking, you can just replace steroid with PRP or a derivative of PRP. Also, the knee, OA of the knee. As Corey pointed out, there's at least a half a dozen studies showing equivalency or superiority of PRP to saline, superiority of PRP to saline, equivalency or superiority of PRP to viscosupplementation and to steroids. And Jennifer just pointed out a good point that in general, across almost all these studies, there may be a little bit of a lag time before you see the benefit from the PRP if you're used to using corticosteroids, but almost always the PRP outlasts the corticosteroids or even the viscosupplementation. It seems to last longer.
Yeah, I think for me, I'm a big believer in growth factors, and I think that's a secret sauce. I'm not a huge believer in actually, so-called stem cells incorporating the structures or putting them in. To that point, I've used acellular preparations for years in most of my regenerative procedures. So having said that, I think the ideal patient for PRP, knowing that in most of us over age 30, which unfortunately of us up here, I think, except maybe you, but anyway, most of us are way past that. So, your growth factors start to go down appreciably at about age 30. In some studies, I think I've seen 35 to 40% reduction at 30. So to me, the ideal patient for PRP would be a young, athletic college student with a soft tissue injury, meniscal tear, tendinopathy, that type of patient, and also because of the price point. I mean, if you jump straight to regenerative, growth factors, amniotic preparations, BMAX, whatever, you can easily get into the $5,000 to $10,000 range. So I think just because we can do this for $400 or $1,000, and in Dr. Davis's territory, it's probably $2,000 because that's LA, but Scottsdale, where I am, it's pretty expensive too, but it's nowhere near LA expense. But I think, offering this to younger patients because they can probably afford $500 or $1,000, and we're not doing any harm to them. I also, or maybe even 15, 16-year-old patients with soccer injuries. I do wonder about what we're doing dumping growth factors in people who haven't finished puberty. That's one of my concerns. So this is another type of patient when, I have colleagues that bring their kids into me, they're 15, 16, tore a meniscus. What would you do for them? Let's do PRP, because we don't know.
Thanks. So, Dr. Hunter, can we talk a little bit more about safety and just go down the line about that, and also how you communicate both what you think is going on in terms of mechanisms when you explain the science and the evidence to your patients, and also how you explain any safety risks?
So I think what other people touched on here, and I think Matt actually just really touched on that beautifully, is that you're not adding anything to the patient. So ideally, whether you're using platelet lysate or you're just using PRP, you're adding it right back to the patient. There are some protocols that I think some people, it's not standardized, which kind of stinks, but there are some things that people don't realize. A lot of questions people have is like, what if they're on a blood thinner? What if the person has cancer? What if the person is taking systemic steroids? So there's a lot of things that are there, but I think it's also common sense. Using just the best practices guidelines that are out there for interventional therapy in general. You're not going to do an intradiscal procedure on someone who's on a blood thinner. So why does it change if you're putting their blood back in them? So things like that, just general best practices for injections, period. But remember, if a person has something like, if they have a tumor, you're going to want to talk to the oncologist and say, is it okay if I put PRP in them and put a concentrated amount of growth factors and whatever it is into a certain area? Like as Dr. Dewan was saying, that there's 2, 3, 4, 5 times concentration. So it's not just as simple as, well, it's a cash procedure, so it doesn't matter what Medicare or these companies think, the payers. So you do have to kind of use a little bit of common sense. Tim Davis and I actually have a textbook coming out this year on regenerative therapies and like across the board. And what we're this gentleman right here actually helped us do pretty much like all of it. So we're going to put in there a lot about best practices guidelines for a lot of regenerative therapies, but in PRP, because it is so much more accessible, I think people reach towards it quicker, but it doesn't make that it's any more safe or less dangerous than anything else.
Thanks.
One of the safety margin we have for PRP or even bone marrow stem cells is that these cells are patient-specific cells. So there is across the board, there is a safety and effectiveness has been documented. So it's really easier for us in that sense to talk to the patient and convince about PRP because this is their own cells. And price-wise, also we have to be very, very careful because depending on where you practice, as Matt said, the area where we practice, we pay thousands of dollars overhead, much more than somebody in the suburbs. So sometimes the prices in that areas might be a little higher. But that need to be discussed with the patient and make sure the patient understands these are all off-label in a way insurance doesn't cover. So patient is responsible for paying for that. I actually started very early on my PRP cases with the spine because that's what I do, and patient actually came with the article that was written by a group of physiatry in HSS, and that was on intradiscal PRP, and that made my life easier. So injection wasn't really because we are doing intradiscal procedure for almost 2 decades, so that's not the issue. Issue was whether to inject or not. And I injected, he did very well, and that made my life easier, and then I started doing more and more.
And we will end with your comment, because we are just about out of time, unfortunately. But if you could give your perspective on that, that would be great.
I'll be short. So the safety is incredibly high degree of safety with PRP injections. You just kind of mind the normal things. If you inject in the knee, there's no heavy exercise for 24 hours to prevent post-injection synovitis. That doesn't matter what you inject. If you pierce the synovium with a needle and you do any heavy exercise, that's the main thing with arthrography, with PRP, with anything, is post-injection synovitis. Also, for the intervertebral disc, Aaron was talking about the rate of infection, and I absolutely agree. It probably isn't even that high. I mean, it's vanishingly rare. I have knowingly never seen a case of discitis in any disc that I've injected, knock on wood, knowingly. I've never seen one. So antibiotic protocol for any time you touch the disc with the needle, it should be, I'll just give you my protocol, and this is a fairly standard protocol we contributed to Dr. Hunter Davis's book, and it's 1 gram ANS effort 2, depending on weight, 60 to 180 to 160 milligrams of gentamicin, depending on renal function. If somebody's penicillin allergic, substitute 600 of clindamycin. If somebody's allergic to all this stuff, use 1 or 2 grams of vancomycin, depending on weight. That's it. Really easy. And the coverage for people that are allergic is also covers literally 99.9% of the people that come through. So that's it, just standard injection safety and do things right, especially along the spine, and it should be no problem.
Corey and I did a paper, and I think it was a chapter actually in Dewan's book a while back about concentrations of PRP. And what we did was we took all the data we could find on all the different publications, white papers, whatever, on concentrations of, at the time, 90% of the different machines out there. And what we tried to do is we tried to make the nomenclature the same across the board and make it all in comparison to whole blood, and then give everybody a very clear, distinct idea of how many times whole blood these different manufacturers created. Because as we've been talking about PRP up here, we've been speaking as if it's all the same. Now, yes, Corey mentioned and Dewan both mentioned A2M, there's different ones, different manufacturers, but you really don't grasp how different they are until you look at that table that we created. And some of them were 0.8 times what whole blood is. Now, mind you, platelet-rich plasma, right? Just say those words. I'm telling you that there was a manufacturer that was 0.8 times what whole blood was. That is a misnomer. That is an oxymoron. They did go up to, what was the top one, 9, I think? Like 9 times? Yeah. So look at that paper, look it up. It'll at least be a little bit of information you didn't have maybe, and then you can make a decision on what machine to use and at least be consistent, because we still don't know, is 9 times better than 3 times? Or is 3 times better than 9 times? Or is it somewhere in between? Right?
Thank you all so much. This has been priceless.
Good to see you. All right, good afternoon. For our next presentation, Dr. Miles Day will be the moderator. He is the Chief of Pain at Texas Tech. And this is a great subject to cover, especially with pain management physicians who see someone come in with a headache and they just want to run or refer them to a neurologist. Yet, as we've seen in multiple studies, a new study just came out, cluster headache doing really well with occipital stimulation. High cervical leads may be helpful for third division trigeminal nerves. I'll let Dr. Miles take this through you. Thank you.
Ooh, bright lights. Great. So happy to be here this afternoon to speak on this, moderate this important topic. And I respectfully request the planners next year to give us more than 20 minutes to discuss this. We could take probably a couple of hours on each one. But thank you, distinguished panel. My first question is, we're going to talk about interventional therapies for headache and face pain, but one of the key things, we'll talk about headaches first. And Dr. Clea, when we're talking about, do you have a definition of refractory headaches? Is that actually, that term exists?
Thank you for that question. I'm going to go back to Romeo and Juliet. Juliet said, "What's in the name?" I think everything is in the name. When we talk about complex facial pain and headache syndromes, this is one very common question which is asked by the fellows and the residents. I think the ICHD-3 has laid out a framework for us to go back and use the same nomenclature for these complex presentations. It is really key and imperative to use a standardized nomenclature for these esoteric and really hard to define clinical presentations of complex facial pain presentations and headaches. So to answer your question, Well, that's a very wastebasket diagnosis. I would encourage everyone to read ICHD-3, International Classification for Headache Disorders, which will give you a roadmap to define and diagnose specific complex facial pain and headache disorders, and use them both for your clinical practice as also research.
Thank you. That's a great answer. Now, Dr. Graywall, we get these referrals, and typically you see the referral headache. And the first thing my staff thinks, great, it's a headache. What are some key things as you're examining these patients with the history and the physical that helps you in coming up with a good diagnosis? Because everybody comes with, I've got a migraine, but not everything's a migraine, right?
That's true, but migraines are very common too. And I think 10% of the population has migraines. So you want to make sure you don't rule out a migraine when it is a migraine. And so it's really important to get a good, thorough history from the patient in terms of onset and progression over time, and really work through it with the patient in terms of establishing a differential diagnosis. You want to rule out the major causes, something that's secondary, infectious in the etiology, or a mass effect. And a lot of times those patients won't present to our offices, they'll present to the ER. And so, then you want to target the primary cause for headaches. And it's easy to get into this kind of knee-jerk reflex where we want to do interventional procedures, and you've got a cervicogenic headache, or you think that it is. But with migraines, the fifth most common symptom of a migraine is occipital pain and neck pain. And so that patient may not necessarily have cervicogenic headaches. And I really try to delineate the etiology of the symptoms before jumping to just a therapeutic modality.
Great. Now, Dr. Hoffman, the title of this talk is Interventional Approaches, but we know that there are other non-interventional approaches. Can you talk about some of those?
Repeat the question, please.
We know that the title of the talk is Interventional Approaches to Headache and Facial Pain, but we know, as in our treatment of headaches, there are some non-interventional approaches, some external approaches, such as some of the new vagal nerve stimulator devices. Can you speak to those?
Yes, absolutely. So we're in a kind of an arms race with the pharmaceutical industry. There's probably been more device therapies on the market now for headaches as well as other neurological disorders. There's also been quite a few new migraine therapies, pharmaceutical therapies. But we now have 5 different neuromodulation devices for migraine and headache alone. And just looking at that in a broader sense, they're also being used to treat other neurological disorders like Alzheimer's disease, sleep disorders, Parkinson's, stroke, with dramatic success. There's a new company called Cognita, for example, that uses light therapy for reducing Alzheimer's disease. There's a new company called AST now that is using sound therapy for both insomnia and Alzheimer's disease. And so the electrical target of the brain being an electrochemical organ, we're looking much more at stimulation devices, because the major networks of the brain basically sync to an electric tune of 40 hertz. That seems to be the magic number. And that has reduced many different symptoms and diseases in neurology, including migraine. And just very simply put, when you have a neurological disease like stroke or traumatic brain injury, the brain becomes noisy, if I can put it like that. And you can be an orchestra conductor with your device and make that brain, the major networks of the brain, the major highways, sing to the same tune to calm it down, to get rid of the pain, to get rid of insomnia, and even Alzheimer's disease.
Great. Now, Dr. Slavin, there's different targets in the face that we address to treat some of the different headaches, such as the sphenopalatine with clusters, and I've even done the trigeminals for migraines. Can you go over some of the data with like the sphenopalatine and cluster headaches with blocks and radiofrequency?
Of course, I'll be happy to. But I think your previous question, we just may add just a second to that. I think you touched on a very important point, Dr. Hoffman. I think when we talk about interventional treatments, we assume that that's something that requires invasive approach. But I think in a wider meaning of interventional, not everything we do has to be invasive. I think what you mentioned in terms of vagal nerve stimulation, transcutaneous supraorbital stimulation, or even direct brain stimulation with either transcranial magnetic or direct current, those are interventions. They may not be invasive interventions, but they're definitely interventions. So that kind of goes on the alternative to pharmacological treatment or behavioral cognitive treatment, which are extremely important parts of actually multidisciplinary approach to that. But when it comes to interventions, and particularly neuromodulation, the targets are many. And they probably correlate with the complexity of the headache and facial pain continuum because it's not just 5 different nosologies. I mean, we analyze different classifications, including ICHD. None of them is perfect, but they just glancing at them, you understand that there's at least a couple of dozens of diagnoses that are very much overlapping and maybe happening at the same time, and it's not as straightforward as some people assume. So when you come to, and not every patient read the book and read classification, so he or she may come with something that doesn't really match the classical description of be that occipital neuralgia or cluster headaches or tension headaches. But based on this, that's where our art and expertise comes into play, because we can choose a variety of different targets for us to address with stimulation, with destruction, with temporary suppression, and so forth. And I think what you brought up, the sphenopalatine stimulation or sphenopalatine ganglion as a target for neuromodulation for cluster headaches, is one of those very few extremely effective treatments, which were shown to be effective in a prospective randomized sham-controlled study, whereas everything else has probably even bigger experience but much less evidence-based. So for cluster headaches, which is very unique, very peculiar condition and very rare, thankfully, but at the same time remarkably refractory to a variety of treatments, the neuromodulation may be a great option. And cluster headache has been nicely responsive to sphenopalatine ganglion stimulation. The problem is it's hard to put stimulator over sphenopalatine ganglion, and that has been challenged from technical point of view for either temporary or long-term stimulation. So the device that was on the market for this in Europe, never made approval in the United States, is not there anymore with the company getting out of business. But there may be resurrected and reborn at some point, and when it does, we'll have to figure out how we can safely implant it, because as a neurosurgeon, I don't go into the maxillary area, and I had to learn how to get there. As interventional pain specialists, many of you are here, you are comfortable probably reaching the sphenopalatine ganglion for injections or for blocks, or even for temporary stimulation, but not so much with permanent implants. So there's many technical, logistical, and other challenges. But I think, going back to where we started, I think making right diagnosis is probably the biggest challenge, particularly for non-neurologists. Right. Because I'm a neurosurgeon. I have a lot of pain colleagues from anesthesia and physiatry backgrounds, and neither of us is comfortable is actually diagnosing the peculiarities of each headache component. So I think this sphenopalatine ganglion stimulation is an excellent target, and we can dedicate an entire session to discussing all this because there's many interesting nuances. But just as you said, there's so many other targets that we can explore, and I think the key is to find the nice match between the patient's condition and what we're trying to do for him or her.
Thanks. Now, Dr. Levy, years ago, there's a big group that started implanting a lot of occipital and supraorbital stimulators for migraines. And I get these patients, and it's like, you know, it's a challenging procedure to do. Your experience with suprastims for migraines, occipitals and supraorbitals?
Thank you for that question. I'd like to quickly echo what Konstantin said. If you go back to the very first study of occipital nerve stimulation that Rick Weiner published, the paper was stimulating for patients with occipital neuralgia. Rick Weiner, of course, is a neurosurgeon. His partner, Ken Reed, at the time, was a pain doctor, and they sent those patients to undergo PET scans to get some mechanistic information. And as soon as Peter Goadsby, who is a neurologist and headache expert, saw the patients, he identified that of their cohort of 11 patients, they were all suffering from migraine headaches. They didn't have occipital neuralgia per se. So it really is important to be able to have a headache specialist involved in your program, and that's one of the benefits that we had with this experience. And what we found in over 200 patients was that all of the clinical trials that had been done up to that point had been well-intentioned but probably misdesigned. So there were 3 trials, one by each of the major stimulation companies at that time. All of them used occipital nerve stimulation for migraine headaches. All of them failed to meet their primary endpoint, although there were some significant positive results, but they all didn't meet their primary endpoint, and they all did not get FDA approved, and their success rate averaged 37% across the 3. Interestingly, the percentage of patients who had headaches either in the occipital region or elsewhere where they could identify that they came from the occipital region was about 37%. And so that led us to do a different type of stimulation, which was, we called it semiotic stimulation because it was such a simple concept. I didn't want to be embarrassed by calling it what it was, which is stimulate where it hurts. We just mapped out on the head where the patients had their usual headache pain and then stimulated those nerves that supplied that distribution. And some patients had 1 lead, some patients had 4 leads, but whether it was supraorbital, auriculotemporal, occipital, wherever it hurt, we stimulated. And with that, in our 50-patient prospective study, we had 1 and 5 year result rates that were more than twice as good as the RCTs. And it wasn't that I did this procedure any better, it's just that we were stimulating based upon a different model. And so in short, about 80% of our patients were getting 50% of pain relief or more, and all of that group had that relief at the 5-year point. So I'm still a great believer, and we continue to have good results. In fact, I just got a text from one of the patients who we replaced her battery after 8 years, who is back at full-time work. Her headaches are gone, and she continues now for her 9th year being headache-free and back to work.
Great. So we got 4 minutes and 51 seconds to go over face pain. Dr. Graywell, kind of back to the, history and physicals are so important, and one of the slides that I have on my lectures is pain in the face does not equal trigeminal neuralgia. Can you, as far as, are there certain things, like once again, like in the history and exam, that would point you to a treatment for face pain versus sphenopalatine versus trigeminal versus neuromodulation?
Hello?
There you go.
Sorry. Yeah, I think, again, face pain is even more difficult at times than headache pain because the patients present in such a varied fashion, and taking the appropriate history can guide you in that direction. And so you're going to look for the distribution of their pain and the longevity of their pain, and sometimes traumatic events that can occur, TMJ, dental history. Those are all things that, we need to kind of pin down before we embark on just, treating, say, trigeminal neuralgia.
Great. So, Dr. Kalia, different ways, if you diagnose trigeminal neuralgia, different ways to treat it. Of course, we do our diagnostic block, but then you have a choice of conventional radiofrequency versus now there's a lot of studies out of China using a conventional plus pulse radiofrequency versus balloon compression. Is there a particular procedure you prefer over the others, and why?
So there was actually a nice paper published by Dr. Jacob back in 2004 in neurosurgery. It was a comparative study comparing the efficacy of radiofrequency ablation of trigeminal ganglion versus glycerol neurolysis versus stereotactic surgery. And across the board, radiofrequency ablation with the thermal lesion of the trigeminal ganglion produced not only superior results as compared to the other treatments, but also long-lasting results as compared to neurolysis using chemical glycerol or stereotactic surgery with that approach. So in my practice, I think if you have a definitive diagnosis of trigeminal neuralgia attributable to a vascular pathology, microvascular decompression is the gold standard and standard of choice. If your trigeminal neuralgia is due to other etiologies, then the option of radiofrequency ablation and or balloon decompression, depending upon which areas you're going after, is the key. With radiofrequency ablation, it's almost hard to get the V1 branch because it takes off two cephalad in order to come out of the orbital foramen. So with the classic foramen veil approach, it's really hard to get the V1 branch as opposed to balloon decompression, where you can non-specifically target all the branches of the trigeminal ganglion. So that's kind of a overall algorithmic approach which we use in our center.
In the last minute and 20 seconds, I'm going to put this as a whole panel because sometimes we have to go beyond and consider off-label use of neuromodulation. Targets, high cervical, trigeminal ganglion, peripheral branches. Just, Constantine, you can start. Do you have a preference of one of those techniques?
Yes. I think I do, but but let me just finish with what Hemant was saying, because what you mentioned is completely correct. I think in my algorithm of trigeminal neuralgia, I would use balloon compression whenever there's first branch involvement and there is no potential, too high of a risk of for microvascular decompression, which is the primary choice for classical one. However, it's not because it's hard to get V1. Actually, it's very easy to get V1 with radiofrequency, but that's what you don't want to get, because the incidence of keratitis and loss of corneal reflex, that's a major obstacle. So you don't want to do radiofrequency for first branch trigeminal neuralgia, even though it's remarkably simple, because it's right there. As you just go deeper, you're going to be in V1 branch fibers. But please don't, because that's much harder to treat anesthesia dolorosa after the well-done radiofrequency in the first branch compared to everything else. So I think balloon compression is much more forgiving and is definitely this. It's actually compression. There's no decompression there. Microvascular is decompression. Balloon is compression. You're really crushing the nerve there with well-inflated balloon. But in terms of targets for intervention, I think, and I use them all, I think the attractive part about peripheral nerve stimulation is low risk. What Dr. Levy was mentioning about his excellent results, he kind of downplayed the fact that he's done hundreds of this, and experience does matter. You can definitely botch the peripheral nerve stimulation. But if you do start doing it more often, then for headache and facial pain applications, peripheral nerve stimulation is definitely safer compared to deep brain stimulation, compared to motor cortex stimulation, even compared to sphenopalatine ganglion stimulation. It's probably on par with experienced people doing spinal cord stimulation, but it's technically difficult to get trigeminal nucleus covered with spinal cord stimulation unless you go from above arch of C1, like we do with small paddles stuck from cephala in a retrograde direction. So I think peripheral nerve stimulation, in my hand, is the preferred thing for neuropathic conditions in the head and face. The second and the next step probably would be the upper cervical spinal cord stimulation, and then I would go to invasive intracranial interventions.
And I know I asked the question of the whole panel, but we're out of time. So once again, I'd like to thank the panel. We appreciate your time and your expertise. And then we'll go to our next series.
All right. That was really a fascinating topic, and it's something I find is rewarding but very challenging, is that type of pain. So For our next panel, it's ASPN. We're going to put the N in Aspen with our neurosurgeons expert panel, led by someone who's not an N, but he's an R, a radiologist, and he was, he protected Brett Favre's blind side as well. So John Michaels is going to moderate this session.
How are you? Thank you, everybody, for joining us for this panel. We spent the morning talking about a lot of minimally invasive procedures that could be used for spinal fixation, SI joint fixation, and now I'm sitting with a panel of experts who are truly surgical experts. And I wanted to start off this discussion to get your opinion on pain management physicians doing procedures that are traditionally surgical procedures, especially when we talk about the utilization of devices like interspinous fixation. And so, Dr. Peterson, we'll start with you. And I wanted to get your thoughts on, again, you have been classically trained in doing spinal fixations, X-lifts, A-lifts, all these traditional fixation devices. And now we're seeing much more implementation of pain management physicians using less invasive procedures. Where does that role fit, especially in your relationship with pain management physicians?
Yeah, I think that's a very important question. And so in my training, we had the transition to minimally invasive treatment of cerebrovascular disease. So we saw the endovascular treatment by coiling of aneurysms. And all of a sudden, open clipping of aneurysms, which is what I learned in my first 2 junior years of residency. Now we had to talk about clip versus coil, and we had to start having that conversation. So it's not the first time that surgeons have encountered this shifting landscape and how we partner with another specialty that ultimately shares the goal for best effective care for a patient. And so the same themes I think are really important. I think it's important, the reason I bring up aneurysm care is because we can use that parallel so that people who have been through a transition once before and see that in the longer term outcomes in terms of patient safety, how minimally invasive options are appropriate to patients who may not be healthy enough to withstand an open surgery, for example. That story is one that applies in several different places within neurosurgery just in the past decade. And so to have that conversation again, to say, okay, this really augments the opportunity. And then the other piece of that is an access issue. So where I practice in Arkansas, there's 25 neurosurgeons in the entire state. And so what that means is really the opportunities to offer spinal instrumentation to appropriate candidates in the state is limited. And that means there's patients who could benefit from access who don't have it. So if we're able to open access and expand the offerings to improve the overall health of our community in some way, then there's a real benefit to bringing more people on board as long as it's done in a thoughtful, evidence and safety-based way.
Thank you. Dr. Dorsey, do you have a certain algorithm that you keep in mind when we're looking at potential utilage of an interspinous fixation device versus a patient who's going to need an X-lift or an A-lift? Is there an algorithm in your mind that we should keep as we're trying to decide whether using a minimally invasive approach or referring to a neurosurgeon for a more advanced approach should be utilized?
I think, yeah, if we're speaking about, so you're speaking about a minimally invasive fusion, I would say, correct? Not an interspinous?
Correct.
So, you have to look and see what's the goal of the fusion. So if the goal of the fusion is to really stabilize an unstable spine, a very dynamically unstable spine, then you're going to want a biomechanically strong construct. And in those situations, I feel that our current technology, albeit in the spine surgery field, is very good. And we've evolved into less and less invasive techniques to do our fusions. So A-lift has become X-lift. Open fusion has become a minimally invasive, fusion through tiny incisions, but with pedicle screws, with inner body fixation, with arthrodesis, and with posterior lateral fusion. So we're still accomplishing all the goals to maximize our outcome. Further, if the goal is to decompress a distal foraminal stenosis, you're not going to get that with an inner, with an inner laminar clamp. You're just not going to get that distal decompression of the foramen, and therefore I think a true surgery is indicated. However, if the goal is just to stabilize microinstability, maybe the patient, will be a little unstable after a decompressive procedure, then I think in those cases, I think there's going to be a great role for these less invasive procedures.
Thank you.
If I could,
Please.
Speak to that too. I think when I look at the spine, I think that the issues of subarticular stenosis, so because of facet disease, and also this idea of vertical stenosis of the neural foramen. And that's where things like interbody cages come into so much play for us in terms of this indirect decompression that we can provide, as well as what it provides us in terms of power of correcting sagittal balance, maintaining lordosis, all these other things that really are very important to the biomechanics of the spine. So, that is a difference I see, in terms of how we approach kind of these topics is some of the power of those options that we have that we use on a regular basis in terms of how we correct the spine in terms of its global deformity, essentially.
Dr. Fulowski, I live in Dallas, and Dallas is a very surgical-based city. And I have to walk a pretty fine line when I'm dealing with my surgeons, because I rely a lot on their referrals for the running of my practice. How do I begin to have a conversation with my referring surgeons so that we can open up the discussion where I'm not stepping on their toes, but where I can actually be a benefit to their practice when offering minimally invasive procedures?
That's a great question. And I started off, earlier today talking about how it just takes education, right? Most surgeons think that you're doing large open procedures now in interventional pain practices and are just not educated on what these procedures actually are. I think you need to probably realize that most of the surgeons have a couple concerns. One is they think they're going to lose their patients, so they're getting their toes stepped on. The truth of the matter is most of these patients that are going to be having these procedures performed in an interventional pain practice are not overlapping with those patients that they're operating on. It's the patients who are older with medical comorbidities who weren't going to be able to go to surgery even though they have surgical pathology. It may be the patients who are, younger, earlier in the algorithm. The spine surgeon didn't want to operate because they're too young and they think it's too early for a fusion. Maybe their symptoms are moderate, so they don't think they're severe enough yet. So these two patient populations, most likely we're not having surgery regardless, so you're not really stepping on their toes. The other thing that I think surgeons worry about is, with these procedures, interventional pain physicians are basically going to have complications that they can't deal with. And we know that actually the way that these procedures are designed now, that they are actually very safe, and they're very safe in interventional pain physicians' hands. So that's absolutely not the case. And the third thing that the surgeons always worry about is, you're going to do this procedure, muck around in the spine, it's not going to work, and now I have a revision spine surgery to fix this. We know very well that with the majority of these procedures, that actually we're still leaving virgin spines. So you're not actually changing anything for this. If there's an interspinous fusion or interspinous spacer that's going in, we're still leaving the bony anatomy intact. So the surgeon's still going to come in and have their virgin spine to operate on. So I think those three concerns are the biggest ones for spine surgeons. And if you can actually sit down and talk with them and educate them on why you want to do these procedures and how you can kind of dispel those three concerns, I think would make a huge difference.
And you bring up a very good point. I'm going to direct this to Dr. Slavin, because when you talk about not leaving something behind, I have a spine surgeon in town who's actually a very big referral source for me, who hates interspinous spacers and has said, I don't ever want to see a patient that you've put one of these in, because he's had to remove, and he was referring to some older devices that were utilized in years past, where he was having to remove so many of them that he has specifically requested me not to utilize those. How would I go about reintroducing that conversation with him with the more modern devices? And as far as use, as Dr. Fulowski referred to, we're still leaving a virgin spine that if the patient needed something further, they're still going to be able to proceed with surgery.
Well, I think you'll have to decide individually, because you probably will have different approach for every surgeon you work with, and so for one of them you have to just guarantee that you're not going to do something he doesn't like, and for others you'll just say that you'll just send patients for him to consultation first, and then you'll take care of whatever he feels is appropriate. There are different ways to manage this. I think I definitely have experience of what you already mentioned. I have doctors in my practice who are strong opponents of these interventions, feeling that they actually harm the patient more than they help them. And I have others who are really are not that bothered by this because they know the patients will come to them anyway, so just a little bit later. And so there are different ways to look at it. So I don't think you're a threat to any of the surgeons, and as long as they realize that, I think you'll be fine. But the general rules of having good relations with your referring doctor, just like for me to have with pain doctors, the same probably holds true for you having with your surgeons. You have to be able, you have to be available, you have to be affable. The same thing that attracts patients to us, make it attractive for our referring colleagues. Now, it's two-way street. If you're going to send all the patients to that doctor for surgery and he will never send you patient for pain interventions, then something is wrong in that relationship, right? You really want to have some two-way street, and it should really work the same way. If he sends you or he or she sends you that patients for interventions and you never have any surgical referrals for them, there's something wrong with that picture too. I think having this clear understanding that you're working together, that you're trying to solve the same problem, that there's certain continuum when you feel like certain things that you've done doesn't work anymore and you need your colleague's help, and vice versa, colleague can call you when he did or does something and it didn't work and he needs you to bail him out. This is something that works universally well in my environment, and I think to have this collegiality and have this, the worst thing you can do is to say, oh, that doctor doesn't know what he was doing and therefore here I am to save you. That will cut the referrals right there and then. So, but keeping things open, keeping things friendly, and understanding the concerns of the doctors you work with. So if for whatever reason he really has issues with one particular procedure, one particular device that you use, trying to understand what that problem is. And if you end up agreeing with that doctor, then you probably will change your practice too.
Dr. Levy, I want to change topics with you a little bit. I've heard it said, don't treat laminectomy pain with another laminectomy. What is your algorithm as far as utilizing paddle leads for spinal cord stimulation?
Well, the first thing I'll say is another approach, although I wouldn't recommend it to dealing with your problem with your referring surgeon, is to let him know of your history and the damage you did back with the Green Bay Packers, and let him know that he doesn't want to mess with you. So, but to answer your question about treating a laminectomy with a laminectomy, I think that reflects one of the biggest problems that I see in pain medicine, and that is people using a diagnosis like chronic low back pain or failed back surgery syndrome. The value of diagnoses is to identify the actual mechanism of the pain that you're treating. And so I get very distressed when I'm referred a patient and their workup has involved being given the diagnosis of chronic low back pain, because I need to know, is it facetogenic? Is it neuropathic? And on down the line, of course. But there are some patients, although in my experience it's rare, because in South Florida there tends to be a lot of over-operation on the spine. I rarely see, but there's always a possibility that the surgery wasn't done completely, the surgery didn't decompress whatever was being compressed and causing the pain, that the problem was addressed at the disc level when it was the stability of that segment rather than a disc herniation causing the pain. So in the case where I can identify a mechanism whereby prior surgery clearly failed, I might go back in and address that with another operation. And that's despite the randomized controlled trial that Dr. North did looking at spinal cord stimulation versus spinal reoperation, because in general, you don't find a clear-cut identifiable cause for their persistent pain, and that's why a neuromodulation procedure is much better. And so I use as many percutaneous leads as I do paddle leads, based upon the age and activity of the person, based upon the trial results, and knowing whether or not they had positional stimulation or inadequate degrees of relief that I thought I might do better with a paddle. But I frequently will use paddles in patients who have persistent low back pain after surgery without an absolutely clear-cut, fixable cause, and I would say that that's probably 90% of the patients who are referred to me. And 90% of those patients, and selection is everything, as we've said before, 90% of those patients are getting good to excellent pain at 1 year, refuse our offer to remove the device at no cost to them, and tell us they'd undergo the procedure for the same results.
Dr. Peterson, do you have any patients that you would not do a paddle lead on and you would strictly recommend utilizing percutaneous leads for implant?
Yes. I would say there's a couple of instances. One is in patients who have some comorbidities or seem more frail. The requirements to heal the laminotomy approach are a little bit more intensive than it is with the percutaneous access. It's a little bit more of an invasive procedure. And I will have that conversation with the patient and say, these are the two options. I think in your case, both are equivalent. And some may by preference prefer one over the other. But others, may completely demur away and just say, wow, that sounds like a lot of invasion of the tissue. I don't want to have this healing, this soreness between my shoulder blades. And based on their expectations for the postoperative period, we may steer towards percutaneous for that reason. The other thing still remains is that there are variable access requirements for MRI scanning. And so in some instances where a paddle is prohibited for MRI access, but percutaneous system is rated for MRI, then I will go to the more inclusive system that allows for diagnostic imaging in the future.
Thank you. And this is for kind of the panel as a whole. I work with a neurosurgeon in Dallas who states that under no circumstances is a cervical paddle lead warranted because in his experience, the patient outcomes are not good using a cervical paddle lead. For the panel, is that your same experience or do you have a differing opinion?
I have wonderful results from cervical paddles, but I will mention that most of the cervical paddles I place are retrograde paddles that go under the arch of C1 and the lamina of C2. You get excellent coverage not only of the axilla, the whole arm, but the shoulder and up to the side of the neck. And with that, you can program to limit the pain, but I have no idea why your surgeon feels so negative about that because my success rate with cervical paddle leads is clearly superior than using lumbar paddle leads, probably based upon the pathologies that we tend to see in the neck as compared to the low back.
I think it'll be interesting if there ends up being an FDA indication for axial neck pain, because in those situations I would still favor a percutaneous approach, as I would find that a laminectomy is somewhat destabilizing as a standalone procedure in the neck and would potentially make their neck pain worse. So in those situations, I would definitely always favor percutaneous leads, and just with a paddle if there's been migration or a reason why they couldn't do a percutaneous lead. The other thought on that is that as systems have changed to subperception thresholds, I think that overall the cervical stimulators are becoming much better tolerated by patients as they're able to use their neck and actually use their device while they're working. I've had electricians, people who are always looking up, that could not tolerate paresthesia-based systems get great relief with new modern technologies.
I wonder if your surgeon was emphatically against cervical paddle trials, a stage trial.
No, it was actually for
just
permanent
paddles.
implantation.
Got it.
I think his concern is exactly what your concern was, Dr. Dorsey, is that the destabilization of the cervical spine. And so taking the different approach that you're talking about, is that always the approach that you take, Dr. Levy?
Not always, but by far the predominant, and we don't remove any bone in that procedure.
We remove a little bit bone so we can charge for laminectomy. Otherwise, you can charge for it because there's no code for paddle placement without laminectomy. You see, there's percutaneous or laminectomy, so you have to remove a little bit of bone to create some code. But that's a different story. But I think what's important is that kind of going back to your previous question about laminectomy for laminectomy, there's very different laminectomies. I mean, laminectomy is done for decompression of spinal canal is wide. It's usually multi-level procedure. It's done for very specific indications, for compression of the spinal elements and so forth. Laminectomy for paddle is much more limited intervention No, we don't do wide decompression on both sides just to put a tiny paddle in. So if the doctor you work with is used to standard spinal laminectomies just to put tiny electrode, then he probably is doing something wrong. The surgery we use for implantation of electrodes are significantly less invasive in terms of amount of bone being removed, in terms of amount of dissection of the tissues around the spine and so forth. So laminectomy by itself, you're absolutely right, it can destabilize the patient completely if you do it in a wide manner. But just for insertion of electrodes, it's very unlikely to destabilize the patient. So I think there's certain technical nuances you have to observe in terms of where to approach, sometimes counterintuitive nuances, so you really have to go from level below just to get a good angle to avoid pressure on the spinal cord and so forth. But in general, there's plenty of room for good indications. Just like Dr. Peterson said, there's majority of electrodes, for example, I put are percutaneous, but there are very specific situations when paddles are good. And for neck, there's always debate because you know the percutaneous electrodes tend to migrate more often in a highly mobile cervical spine, whereas in more older sclerotic spine, the migration probably will not be that big of a deal. So there's indications if patient has something for post-neck surgery syndrome, which is a combination of radiculopathy and chronic inflammation and so forth, versus CRPS, which will maybe just perfectly controlled with somewhat off-midline position electrodes percutaneously placed. So there are all these nuances that we take into consideration, and I think just brush off this modality because it just doesn't work or because it's too dramatic or too invasive would not be right.
Thank you all for your time today. We really appreciate you. Thank you very much.
All right, so that was always fascinating to hear the neurosurgeon's perspective on a lot of things, at least from my standpoint as an anesthesiologist. But as neurosurgeons typically do, is like when they post a case that's going to take 90 minutes, they usually take 2 hours. So we're running a little bit behind now, but we're going to catch up here. So our next is a very important topic. We don't want to rush through this. So it's on diversity, equity, and inclusion, a call to action, led by Dr. Natalie Strand.
Don't walk out the door. This is an awesome panel, everybody. I think we just peaked. We're done now. No. I didn't say it, but. All right, it is my absolute honor to be the moderator for this panel. This is one of the things I love about ASPN is that diversity, equity, and inclusion is a big part of who we are. It's a big part of where we put our energy, and we definitely illuminate not only our members, but the cause and what we can do. So today's panel is diversity, equity, and inclusion. It's really a call to action. And one thing I want to start with is that this is everybody's issue. It's not only affected by those who are underrepresented in our field. Diversity drives excellence. It's necessary for the pain medicine community to be aware of the inequities based on race, gender, sexual orientation, ethnicity. For example, women make up only 18% of department chairs in academics and only 25% of full professors, and this is in an age when women are more than 50% of medical students. Performance reviews use more positive words to describe men and negative words to describe women. And I don't think this is conscious. Nobody writing these reviews, men and women, are doing this on purpose, but it's this implicit unconscious bias that continues to affect us. Women overall get smaller NIH grants than men do. And this is also well known regarding racially or ethnically underrepresented individuals. The minority tax, this includes isolation, lack of mentorship, additional clinical assignments, career limitations, implicit bias. Black men are only 3% of all physicians, and black men make up only 1.6% of all full professors. And these differences for everybody affected has a long-lasting impact on our colleagues, on ourselves. It impacts our career, it impacts our salary, it impacts our mental health, and it even impacts people's decision to leave medicine all up, all in. So before we even start, I just want to put that lens. It is everybody's problem. It is everybody's responsibility to contribute to a solution. And thank you for everybody for being here, and thank you to our panel of experts. So with that, I'm going to start with Dr. Ghosh. I'm glad you made it. She had to race through traffic to get here. I just want you to go over some of the basic terms here. I'm going to start with stereotype threat, if you don't mind kind of talking about that.
Sure, I'm happy to. So I think stereotype threat, the major way I see it is that it puts you in a box for whatever people may think of you by looking at you. So if you're a short young woman, for example, they might think you're docile, and if you don't fit that, then you might not fit their mold, and they might be more offended by you. If you're more aggressive, they might see that in a really negative way. So I think the problem with stereotype threat is they always have an idea of you before they actually get to know you as how you are as a person, and I think that really threatens what you're offered, how you're perceived, and kind of going from there, it gives you either a negative way that you fit into it or you don't. And so I think it always limits who you can be, even if you're very different than what they might perceive you as.
Thank you. It's a complicated thing to explain. You did a great job. That goes hand in hand with imposter syndrome. And these are terms we just need to be familiar with in this space. So can you talk a little bit about imposter syndrome?
Yeah, so I think imposter syndrome is something that everyone feels at some point or the other, but it's been documented in multiple studies, multiple papers. Women and minorities, especially in high-powered fields, feel it more. And what imposter syndrome is regardless of your accomplishments, regardless of how competent you are, how good you are at what you do, you constantly feel like, oh, I don't belong here. Someone is going to find out that somehow I've snuck in here. For example, on this panel, I'm like, what am I doing with a brilliant neurosurgeon, these brilliant professors, and how am I here? And that constantly affects the work you do, the opportunities you seek. And so it's one of the biggest reasons for burnout, actually, documented in medicine, and it's certainly pervasive every step of the way.
And as a follow-up to that, representation, they say you can't be what you can't see. So tell me how being represented and seeing representation or being representation plays into that.
Yeah, so I think representation is probably the most important thing personally to me, other than mentorship, because so many times when I used to come to conferences, I used to see no one who looked like me on stage, and I always felt like there's no way this is going to be me. And then I remember I was giving a talk at NANS, and one of the women stood up, and she was a minority woman, doctor, very senior, and it made me feel like there were people who were like me. And the more I see it, a panel like this, not just on diversity, but a panel like this on PRP, on surgical indications, the more you feel like I belong, I can be there. And I think that there's probably nothing really more powerful than watching a female moderated panel, have diverse panelists who have the same level of knowledge as anybody else, and you feel like it will really make you feel like you belong and you can do the things that you aspire to do.
Thank you for that very honest answer, and you do belong. And I think we all have imposter syndrome all day long. So, Dr. Guri, the next question is for you. I had the honor of writing a very important paper with you that was published this year, Racism in Pain Medicine, that was published in the Mayo Clinic Proceedings. One of the things that we worked on there was an inside-out approach for the pain medicine community, involving all the players. So I'd like to ask you to talk a little bit about our proposed inside-out approach to eliminate racism in pain medicine.
Yeah, no, I appreciate the question. I think the important point of that is it starts with us and permeating out to the rest of the community. I speak in a lot of sports analogies, but in the idea of diversity, equity, and inclusion, I'll actually change my analogy. This morning when I was getting dressed, I saw Fresh Prince of Bel-Air, which is my favorite show ever, and I'll fight you if you disagree. But one of the things that I think made that show special is there were so many elements of comedy that came from different experiences. So you had like the butler, you had the dad, you had the son who was the rapper, you had the son that was a nerd. And that's really what made the show special. And I think as we look at every field in the world, not just medicine, when you have people who bring different experiences and bring flavor to what you're offering, I think we know that the outcomes are going to be better. And so if we take that and look specifically at pain medicine, we have patients who are really at a low point in their life. They're going through situations that are, and they're sharing very intimate information with us. and we're taking that information and we're, working together to improve their quality of life. Unfortunately, that social contract has been broken a lot historically. It's been broken with me personally. And so really ensuring that, one, those patients feel comfortable sharing the information that we need to improve their care. Two, that we have the best team that's put together, a team that comes from different backgrounds, who've had different experiences, to understand a lot of we know that pain is not just physiologic. We know that there's social stressors and psychologic stressors that contribute to pain. So having a team that really understands that and making sure that we're able to bring that to bear and no longer break that social contract to make sure our patients do well.
Thank you for that awesome answer. You highlight something that's really important, that diversity, equity, and inclusion is at all levels. It's in patient care, it's in representation among paying physicians, so it's good to consider both sides. Dr. Peterson, you're next. Female neurosurgeon, I know that you're definitely in the same boat as the rest of the females in pain medicine as being the minority gender in your specialty. I know you get asked to speak a lot, and I know you're a big sponsor for other women, but one of the things people often talk about is the pipeline issue. When you want an expert for a paper, you want an expert for a talk, it's like, oh, well, there just aren't any women. So what do you say? Is the pipeline issue real? Is there a solve here? What is our responsibility as a society and as individuals to help with this?
Well, the pipeline issue is real. That's been shown in looking at where attrition is and where the progression is within development in medical and surgical fields. I'm one of 20 full professors in neurosurgery who are women in the US, and I've been out of residency for 11 years. When I was in training, there were no female professors at any rank in my residency program, and very few. And so it is only by conscious effort, and in my case, a lot of support and mentorship and coaching that I received from non-women to get me to this point of accomplishment. And so that's where the call to action piece of this exists. It's not just about people who may represent an underrepresented and less visible group speaking up and being available, but it's actually for everybody who can recognize as they're organizing an event, what can I do to try to promote forward? And not just to pick somebody that you already know, but to maybe elicit that person. I've had people come to me and say, you know what, look at this agenda. Does this look like we're representing and gonna reach the right group? And I'll say, yeah, I think this is great, but you know what, you've got a really great talk here, and I met so-and-so, and this person, you wouldn't think of asking her originally, but if you put her on that, it's gonna be phenomenal. And so what I think is really important there is that anybody who's in an opportunity should look for those opportunities. And what that ends up doing is the diversity of perspective that we build by encouraging new participation and new voices. That's what allows the diversification of our field. It allows for innovation. And where that happens is from the people who are already at the table. Pull an extra chair up, ask somebody else to come sit down. We do it all the time as educators, as mentors, and as sponsors. And if you look at the organization and you're participating in an event, and you find that it's pretty homogenous, the group that you're teaching with, just say to the organizer, hey, you know what, I went over this roster. Did you know that you don't have any women on your faculty list? Was that an oversight? Because I can tell you 2 people I think you should probably want to include. And if you speak up that way, that event will be a better event because of the participants getting the benefit of those perspectives and education. One of the most important things that I think is valuable is that male trainees experience what it's like to learn from an authoritative woman with experience. Because that means that when they run their OR and they're interacting with women peers, when they're interacting with other women in leadership, they've had those models and they have experience and they're able to train. But if they're training in a non-diverse place, then when they go out into their own leadership, they're going to promulgate some behaviors that may become toxic and that may ultimately hinder their own ability to succeed and their own ability to have the ability to advance.
Thank you for that great answer. Dr. Weisbein, you're next. I'm gonna dovetail on something Dr. Peterson said about how active you have to be to make change here. Pushing change in this space requires, conscious effort. You have to be, very, very purposeful in integrating it. So I want to talk a little bit about allies. Somebody made a joke to me the other day, like, oh, I'm a white male, so it's my fault. And I thought, it can be tough for people who feel like they're the scapegoat of everything that's wrong, but the truth is that our allies, it's just a term we use a lot in the gender and equity space, but it applies to all of diversity and inclusion. If you're an ally to somebody and you bear witness, it's really important what you do in this space. So Dr. Weisbein, I'm going to ask you to talk a little bit about what our allies can do. And then I'd love for you to also just make a small mention of the difference between mentorship and sponsorship under this umbrella of our allies.
What a great question. First of all, I just want to say that I love listening to my peers here talking about this, and we've focused a lot about male versus female, but we're living in a day and age when there's so much more beyond that with gender fluidity, sexual orientation, and all of those things play into a factor if we really wanted to take count if any of that matters to us, because really it's nobody's business what you do behind closed doors. But recently I heard a story of a resident who came dressed to work in the clothing of the opposite sex and was sent home to change because they were told it was unprofessional. And the person that was retelling the story was one of the attendings in the program and was asking how could they be an ally for that person and how could they support that person better. And so, I said, well, thank you for recognizing that this person was probably hurting, A, and B, how can you, with that resident perhaps, create a implicit bias training or something in your program so that you're able to teach other people that the things that we bring to the table from our own background, growing up, socioeconomic status, all of those things contribute to the way that we view the outside world, right? Just because we view it through this small lens, it's not the lens that anyone else shares necessarily, right? So how do you become an ally? Unfocus that lens for a second and put yourself in someone else's shoes and imagine how you would feel if someone chastised you about your religious belief or anything that you love and hold passionate to. And when you can take away that feeling of, wow, that would really hurt me, and how can I support that person? That's how you start the step of becoming an ally, right? Because you don't need to necessarily agree with someone else's desires, behaviors, beliefs, but you at least need to be able to say, like, I support you because that's what gives you happiness, right? And then beginning to continue to, support each other by an ally is someone that says, I see you, I recognize you, I understand you. What's the difference between that and mentorship and sponsorship? When you mentor someone, you're helping teach them, give them instruction, but to sponsor someone is to actually point out and bring them up. Eric and I talk about this all the time, right? So, if someone is in that pipeline and they keep asking the same person over and over again, the same woman, but we can't always do it all the time. One person can't always be the same person. And so you sponsor someone else by saying, but I know this other person that would be an excellent candidate for this. Like Erica was saying, that's a way to pull someone in and offer them sponsorship because you are already believed to be someone that is thought to be of that level and caliber. And so you vouching for that person is essentially giving them credence and the ability to get to a table that they might not be able to get to. I'm constantly amazed by when I interact with some of the younger fellows that are coming up and graduating and they lack that confidence and they feel like they don't deserve to become a part of the conversation. And I think it really requires each of us to take a moment to help the up-and-coming generations of physicians to recognize that there is a place for them here and they can have a part of that conversation.
Thank you. That's an excellent answer. Dr. Meacham, we've talked about a lot, but I'm going to ask you on the data side to use your MD PhD background here. Could you talk to us about some of the data-driven strategies to mitigate, identify, resolve unconscious bias? I think we all know that everybody has bias, but a lot of people, well, we all know that everybody has bias. Let's normalize that. Nobody is totally unbiased. But what are some data-proven strategies to identify your own biases, to mitigate them, and hopefully eliminate them?
Thanks. I do think that probably one big step for me in understanding these issues was that I did not recognize my own implicit bias until I took some tests. And so there's Project Implicit. If you go to implicit.harvard.edu, it's the Wash U of the East Coast. And you need to understand that you do have implicit bias. It's unconscious, but once you recognize that, the rest of it comes pretty naturally. But you do have to, and so there are ways to do that. There's data-driven ways to do that, and there are lots of training that you can get in order to understand as a leader how to be inclusive, how to reach out to cultures, how to understand other cultures. And so there's plenty of data about that, and I do think that it's important also in every case that you're trying to understand it, that you take the time to listen. I think that the strongest mentors and sponsors that I've had taken the time to listen, because it's not just about one aspect. You are helping somebody come up in a field, and how we look and it is oftentimes very different from things that are important about us, and you just don't know. But I think understanding fundamentally that we all have it, that everybody has a role, everybody can be re-engaged, and that it's not, and especially this past year, it's everybody has had opportunities to feel like they're more isolated, that they're more hated, that there is an other that is bad. And so it's a great opportunity for us to take a step back as leaders in the field and as doctors to really be conscious about undoing that and realizing that we are all the same in terms of being humans who have bias, who don't feel like they belong. And that doesn't really, I don't think that goes away for whether or not you're a female or of another race. I don't think anybody truly feels like they belong. And so understanding that and being up here and doing these things, and one thing that I think that we can do that ASPN has done very well that we really should do is in the past year we have become so good at being virtual. And if we're going to bring, and so I come from a clinical practice that has more women than men as faculty at this point, and they are in the positions of leadership. They have a barrier to attending this. I have a barrier to attending this because you have to fly somewhere to do it. And we have this opportunity to include other people by holding on to the format that we're in and continuing to really leverage the technology, because otherwise, I don't think, so there are barriers other than being invited. It's getting here and doing it. And we've lowered that barrier this year, and I think that that's an aspect that ASPN really needs to continue to lean on in order to close that gap.
Very well said. Thank you to everybody for your wonderful answers. I really appreciate it.
That was outstanding. I think it's an important topic that will continue to kind of dedicate a lot of our, our prime time slots through ASPN as we go through our meetings and those types of things. And the other good thing, Dr. Meacham brought up a good point about the virtual. One thing I enjoyed when Dr. Meacham was able to join us for our virtual meeting last year is I was able to peek inside her kitchen. She has a wonderful backsplash, so that was great to see. It's another advantage of the virtual meetings. So next I'll have Dr. Doug Beal, who really needs no introduction when it comes to vertebral augmentation. He's going to talk with our expert panel about what's kind of new and interesting and exciting with that.
Thank you, Dawood. Well, let's talk a little bit about vertebral augmentation, shall we? So this is one of the things we do, two things we do in medicine that's demonstrably life-saving and life-prolonging, right? Hip fracture repair, spine fracture repair. And there's been a lot of new things to come down the pike. The most recently approved implant had 3 superiority claims over the predicate, which is the first time in 36 years of vertebral augmentation that has happened. So I definitely don't want to hog the stage when we have such esteemed experts up here. So I guess I probably should start, maybe Dr. Escobar. What do you think the most significant advancement has been in the last 1 to 2 decades of vertebral augmentation?
Probably the most significant advancement is early recognition and earlier treatment of compression fractures. One of the things you've demonstrated was the number needed to treat to save a life. There's nothing more rewarding than offering a definitive therapy for a condition that is undertreated and really underdiagnosed. We were talking earlier about 25% of patients that are identified as having a compression deformity are not treated, appropriately, and the failure of conservative measures really is something that should not dictate by time. I think it's critical to treat these early on, but to answer the question specifically, the use of a titanium implantable vertebral device has really changed the scope of how we can offer better height restoration and longevity for compression fractures.
It's a good answer. I like that. I might want to shift gears a little bit with Dr. Weisbein. One of the things that I find really mystifying to me is why people don't treat the underlying disorder for the lion's share of vertebral compression fractures, which is osteoporosis. I was giving a talk one time and I showed a slide. Is my routine to treat uses anabolic bone agents like abaloparatide, and I referenced a relative risk reduction of 86%. I went on to talk about the EVOLVE trial, and I wanted to demonstrate the superiority that gives you in outcomes, because our site in the EVOLVE trial out of 24 was statistically significantly better in terms of pain and functional improvement than the other 23 sites combined, which is extremely hard to do, exceedingly difficult. And one of the guys in the audience who I know came up and said, it's a little bit like cheating. I said, what do you mean by that? I said, well, you showed a slide that 86% less fractures treating with anabolic bone agents, and the regression analysis said you were the only one treating anabolic bone agents. Of course you got better results. It's a little bit like cheating. So, well, I disagree. The difference is you can do it too, you just don't. So, Jackie, what's your protocol for treating the underlying disorder after something that has a mortality of 8.6 times age-matched controls? We really need to do something about it, because I can tell you that in the community of people that do vertebral augmentation, this is still, unfortunately, very unusual. So could you just give me some of your opinion and your approaches about this topic?
Yeah, so thank you for that question. I think it's really easy for all of us to come in and be the hero and do that kyphoplasty or vertebral augmentation, but the reality is what happens with that patient after the fact, oftentimes they can have a subsequent fracture. And then, the reality is how do you care for them? If you talk to me during some of my pump talks, those are my favorite pump patients, but really I'm still not treating the underlying issue. When I joined the orthopedic group a few years ago, I said I really want to identify this patient population, not just to do vertebral augmentation, but also how can we create kind of this osteoporosis center of excellence, because in my town of Napa, there happens to be one 85-year-old endocrinologist who I think is retired, and a woman who practices every other month, one day. So we don't really have someone that's actively treating it, so it kind of fell into our lap if we were going to be treating vertebral fractures, fragility fractures. And it's not unique to just me and my spine surgeon treating them. There's also people that we identify that come in with occult fragility fractures from their femur or their arm, and so identifying those patients and then putting them on a trajectory of treatment and understanding what have they done and what haven't they done. Oftentimes these patients have also already been on some kind of medication like Fosamax or something and maxed out at the 2 years, but these new agents like Tymlos and what you were describing that are bone building agents can be started and managed. So we basically trained our PAs. There's a lot of online education training for osteoporosis management, and kind of set them up to be the go-to people to manage this. And we kind of created this education program for them, and then we also educated our community so that instead of these patients getting admitted to the hospital and languishing in a sniff, we said, okay, refer them to us, we'll get them in within 24 hours, we'll work them up, we'll see what's going on, do DEXA scans, things like that, so we can identify and treat them. And so I think the reality is that, there's not a lot of other procedures that we do in the pain space where we just treat them and send them on their way and say good luck, Godspeed. This is something that requires a continuity of care. And if you believe in this therapy and how amazing it is to help people feel better, then you need to continue the next step, which is that ongoing management. These medications, if you go to some of the dinners, it's interesting. There's a lot of primary care, but they still don't understand the science of how to apply it. They don't understand, is it an issue or isn't it an issue if the patient's already received other agents prior. So I think identifying those things and kind of creating a program for your office is really going to set you apart from anyone else in your community that's taking care of these patients, especially if it's interventional radiologists who are doing it, right? Because they are not really doing any continuity of care. They do the treatment, the patient goes home. Oh, I'm sorry. I'm just joking.
That wasn't even planned. That was pretty good, Jackie. So, all right, Matt, I'm going to give you a hard question. This is probably the toughest question so far because it wasn't on the list that I gave you. But
get the list.
I really want to know the answer to this. One of the biggest points of disappointment coming to meetings that are interventional pain is that more people are not doing vertebral augmentation. That so few, relatively, compared to some of the other technologies and some of the other devices that we have, relatively few people doing vertebral augmentation. So why do you think that is, and how can we improve it?
Well, I think the most telling thing is when I have colleagues in my own community go, well, how are you getting 10, 15 kyphoplasty patients a month? They don't know how I do it.
Right.
So how do you do that? Well, and to everyone's point, I mean, we have done a great job, I think. Well, people like you, your generation, you've done magnificent work with getting the word out on kyphoplasty and fighting all this very poor quality literature that's come out that suggested we shouldn't be doing kyphoplasty. But to your point, I think the biggest problem is still educating not just the primary care doctors, but look at what's happened over the last 10, 15 years, since I finished my training. You no longer have, in many cases, at least in my community, I'm sure most people have the same thing, the physician isn't really seeing all of these patients.
Right.
It's physician extenders. And so that's been a challenge because, my 60-year-old, big-time referring primary care doctors, they understand and they personally send these patients to me, but that's maybe 10% of the volume that runs through their office. It's all the other physician extenders. And you would be surprised when I go and talk to emergency rooms, because that's a huge thing. You got to get them in the ERs. I found that to be even more fitting than talking to primary care doctors and more productive, because what I have found, and I'm sure that's probably your experience too, so the patient comes in with a vertebral fracture, where does the loved one usually take them? They take them to the emergency room. What does the ER do with them? Until I talk to them, mostly they either sent them home, sent them back to their PCP, or many times they sent them up to the SNF unit or to rehab for two weeks. And we all know what happens in rehab to somebody with a fracture.
Right.
So I think it's incumbent upon us to keep going out, and I know it sucks. You got to go spend your time during the day when you could be making money, but you really need to do that. And I even go back to the same ERs like every year because they've got new PAs there. And again, same things happen in ERs that's happening in primary care. They've got ERP and emergency PAs who have never heard me talk about it, know nothing about it, and they just sort of follow this prescribed, let's dump them on somebody else. That's what I see happening.
I think that's a great answer. So out of our center, we had one time measured everything surgical and interventional we did with the spine. So out of 24 things, vertebral augmentation was number one in terms of patient satisfaction and outcome. So it hopefully will give you a little bit of motivated. Dr. Jane, I would like to know your opinion on, out of the evolution from vertebroplasty to balloon kyphoplasty, now implants and maybe beyond implants, this kind of home mix. I mean, is there a single component that can be improved? Where do you think the primary focus over the next 5 to 10 years should be in this continuum?
So I think we've made significant advancements since balloon kyphoplasty. We've focused on improving the cements, the devices. We've had directional IBTs now for balloon kyphoplasty. We introduced implant augmentation. Kiva did the CAST trial. Stryker had Seiko's trial. Both showed significant improvement in adjacent fractures, and less cement extravasation. But I think the future holds what is really needed is a way to stabilize unstable fractures.
Yes.
And I think we need something, like a pedicular fixation with stabilization device that can improve, even improve further the adjacent fracture rates and, reduce the need for surgical intervention and have more percutaneous advantages.
Boy, I love that answer. I do. So Harry, kind of to pick up on that last topic, what is the next generation, let's say post-implant, whether it be a Kiva or a spine jack that we use in the United States, maybe an OsseoFix that's used in Europe, what does that next generation implant or system look like to you?
Well, to me, I think, I look at vertebral augmentation in 3 bits. One, we have access, then we have height reduction, and then stabilization. I think, over the last decade with steerable and directional devices, access has become a lot easier with regards to height reduction. We've gotten some degree of improvement with implants, but finding something that is able to stabilize an unstable fracture, I think, would be remarkable. And then the most dangerous part of kyphoplasty, in my mind, is really cement delivery, right? That's where we can run into some issues. So having a better ability to control the cement delivery and deliver it in a more uniform manner, a more intended manner, would be ideal.
Great. With that, I'd like to say thank you very much for the expert panel members. At this point in time, we'll take a break, and we will resume in 30 minutes. Okay, go ahead.
Great job, guys.
Thanks, man.
Great job. Staying on time. Okay, so we are kind of winding down with our last two panels of the day. I think these are going to be a completely different flavor than what we've had earlier on, as that we're talking to our industry partners, some of the bigwig executives involved with bringing a lot of these therapies that we talk to our patients and for us to incorporate them to our practice. So this next panel that Tim and I are going to moderate are going to be perspectives from leaders in industry on the future of interventional pain and neuroscience. So I'm going to let Tim kick it off and give the first difficult probing question.
Well, I don't know how difficult it is. By the way, thanks for coming back for the afternoon, because I will say that when you're at the beach at a meeting, we have about 1,400 people here. The beach tends to draw people, but I'm glad you came back to join us this afternoon. We have just a little bit of time left. I think it'll be an interesting discussion. We have a variety of panelists here, and I think we'll start off. I think I'm just going to go down the line a little bit. Malik, I'm going to ask you the first question, and that is, here we are in 2021. What year did you start in the industry of neuromodulation? 2012. So 9 years.
Yeah.
So again, I've told all you folks not to ask you any really hard questions. So we're going to take turns asking you questions. So if you get a hard question, it's Dawood's fault. But so I guess the question is, for neuromodulation-based companies like yours, you expanded. You went to an interspinal spacer. What's the next 10 years hold? Are you going to remain a neuromodulation company primarily, or do you think that companies like yours will transition where it's hard to really say you're a neuromodulation company anymore because there's so many other things? What's your best answer to that?
Probably it depends on the space. So, for example, in pain, we have transitioned already, looking at multi-therapy approach. The focus has always been on what's important for the patient and how do you really practice and partner with an interventional pain physician and really creating a toolbox of providing different solutions for that patient at that time, what may be the best and optimal solution. And I'm not sure just looking at neurostim as the only solution. And in DBS, we've started out in deep brain stimulation Parkinson's. We'll always look at other options, because at the end of the day, you have to figure out how do you really treat the patient in the life of the journey of the patient. It's probably the best way I can answer you.
No, I think that's a great answer.
Michael, after you briefly introduce yourself and your background, I have a question for you as well. You've been in this industry of pain and neuroscience for a long time. What's kind of the industry's viewpoint on our specialty right now and the future outlook for us?
Well, thanks for the question. It's nice to be here with everyone. My name is Michael Enzing. I'm the Chief Commercial Officer for Boston Scientific Vertiflex in the Neuromodulation Division. I think what's really exciting to see is you first have to kind of peel that question back a little bit and look at the addressable market. Anytime we get excited about something, what truly is the addressable market? How many patients are in the system today? How many patients are entering the system each and every day? Then there's what I think is probably the most exciting time. There's great investment, and that comes from a lot of the companies that are represented here that are very passionate about patient care. Ultimately, when you look at your colleagues and the technical expertise that you have, you've harnessed the power of technology. Fluoro is an example. So if you can understand the addressable market, you can attract high-quality investment through venture capitalists or the larger companies. They create all sorts of new opportunities to harness that technology, but it's meaningless if you can't drive efficiency. And if you look at interventional pain, it drives efficiency. We could call that locations within an ASC as an example, but in general, specifically the fellowship programs, great physicians having meetings like this where it's educational, having great investments from the company where they spend an enormous amount of money to replicate and train and do disease diagnosis and understand that. When that happens, it just works. And so really, the next 10, 15 years in this space is going to be incredible because all those things are merging together.
Great insights. Thanks for that. David Caraway, used to be in practice in West Virginia, greatest state in America. You actually, you've seen quality physicians, you've seen non-quality physicians in your career. I guess my question for you would be, I've had a lot of young physicians ask me, how do you get invited to do research? David's a medical director of a large company, and they say, what do you have to do to get invited to do research? And I think that's a question a lot of people that are here would really like to know your insights on. How do you choose a center, if you're going to do a new research level 1 study, how do you choose who you're going to work with?
That's a good question. And, one of the things I'm most proud about is before I came to Nevro, there was an attempt to be disruptive through evidence. And I think everybody up on this stage knows that Nevro did disrupt the space in a good way, right? Raising the bar on evidence building. And the way that we approach the role of evidence and how to bring people in is the same way. It's to look at something that's going to make a difference. And to define that field, of course, you corporately look at things like Mike was saying, looking at addressable market and what alternative treatments are and all that. So, of course, we do that. When we go to speak to individual sites, for example, which I think is your question, and what we're looking for a history, frankly. On a big, large-scale randomized controlled trial, you don't want to have a novice first-year out fellow contributing to those. There's roles for novice people who are just beginning their research careers. But certainly if you're going to invest millions into a large-scale randomized controlled trial, it's important to have centers that have research coordinators, that have the bandwidth, and very importantly, they have the patient base to contribute to whatever entity you're trying to study. And they vary. Then you want to have a diverse study sites, right? You want to have academic, you want to have private practice, you want to have small, you want to have larger ones, but they all have to be that quality. So what I encourage the young guys to do, if they're interested in this, is to begin probably not in that level 1 randomized controlled trial. I don't think they're set up to do that. There is a path that all of the companies up here have for what's called investigator-initiated studies. So this is when an individual or a practice has an idea of something they want to research. And they write a protocol up and they bring it in typically into a committee or a group within industry. And they examine that research project and say, is it a good fit with my company? Is this something we're interested in? Is the research meritorious? Is it novel? Can we get it published? So that's how it works, and those are the studies that I think young guys ought to think about. And then there are post-market studies, which just about anybody can do, registries, commercialization, and that's very often sponsored by industry to get some sort of post-market surveillance metrics. All of those are available, but they come at different points in your career.
Great. Wonderful answer. Thank you.
That's great. So, Mark, you work with a company, SPR, and that was kind of founded by Dr. Maria Bennett, who couldn't be with us, and thanks for kind of stepping in for her. I think you guys have a pretty interesting story when we kind of talked to piggyback on research, where you've been able to partner with entities like the DOJ and those types of things to kind of help fund some of your research as kind of at an earlier stage in your company. Can you share a little bit about that pathway?
Just to clarify, it's DOD, not DOJ, for the record. So I thought you all wanted to know that.
Mark is winning this panel right now. Mark just won the panel, I think. I'm just saying.
Where's his orange jumpsuit?
Yeah, we've been really fortunate. We've got, in addition to Maria, who runs the company and built on her early work in graduate school with Dr. John Che in Cleveland, we've got a phenomenal research team. Dr. Josh Boggs leads our research function. He's got a team of 4 other PhDs who are experts in writing grants, and there's really no other way to say that. They're brilliant, number one, and number two, really know how to navigate the process. It's a ton of work. They're very hard to get. We've raised about $30 million in non-dilutive financing from DoD and NIH, and now we're kind of on our own path to do that on our own and fund them ourselves. But I think it starts with really good people, with good technology, good ideas, and an understanding about how to navigate what is a very competitive, arduous, detailed process.
No, I think that's a great answer, Mark. And for those of you who don't know a lot about the grant process, when you have a non-diluted grant, it means it doesn't dilute your company's value. So it's really important when you're a startup company with things like Department of Defense and injured soldiers. So Keith Bettiger, you lead the Abbott business for both spine and brain and led that business for a while now. And I asked Malik at the very beginning where he thought we were going to go, and I'm going to ask you a little bit different question. It has some of the same implications. There's many, as you go through that exhibit hall, there's many companies there that are new. Some of them we didn't hear of until last year. Some of them have been around for 5 or 10 years. When you assess, a potential collaboration with a small company, investment, acquisition, what are the things that you're looking for, and what are the things that would make you think that might be something that we'd want to partner with as a business?
Well, I mean, I'll go back to what Mike said. I mean, first we look at the population of patients that are out there and how well we think we can penetrate those patients and how that population of patients is going to grow long term. And then when we're looking at other companies, we look at is there intellectual property that's going to protect the product long term and give us a path to commercialize the product and kind of run by ourselves for a little while, or is it a product that is a good opportunity, but maybe doesn't have intellectual property, but we think we can go in and dominate in the space. So we look at market size first. We look at make sure it's in the channel. So we have two businesses too. We have the pain business and the DBS business. But in the pain business, we look at really leveraging the channel. Because as everybody knows in this room, the sales rep is a really, really important part of the interventional pain products, and they do a lot to create demand, to manage kind of the patient from interest all the way through implant. And so the channel is really important. So can we take a product, put it in the hands of our current sales rep, and then how much service burden is that product going to add to that sales rep's job at the end of the day? Because if it's going to add more service burden than a spinal cord stimulator, it's going to be a little bit tough. So we're looking for things that you can sell in. The physician can do it on their own, right? We can sell it and give some support, but we can't add a lot of service burden. But we want to leverage the channel, and then, ideally have intellectual property. We'd have protection to go at it.
Very good. No, great answer. Thank you.
Dave, you work with Medtronic, which is one of the, if not the largest, medical device companies in the globe. So I'm always curious, Medtronic has their hands in almost everything from diabetes to cardiology to a lot of things we talk about in neuroscience. So when you have a portfolio that's so broad, when we talk about some of the things we talked about today, like minimally invasive spine, that could potentially, from a company standpoint, I could see you guys, would it affect one part of your business? How do you balance that? Like say something is in neuromodulation, neurostimulation, or minimally invasive spine, that could hurt your spinal deformity business. How do you guys balance that?
It's a great question, and I look at it as kind of two sides of a coin, and what's most important is ultimately the patient outcomes. So as we look at it, I thought today's agenda was outstanding, looking at all the minimally invasive spine opportunities. And we look at it from a care continuum perspective and say, what's the best treatment at the right time for this patient? And from an unbiased perspective, we ultimately look at it as, since we own that care continuum, own's a strong word, but since we have a play in really across that entire care continuum, how do we ensure that we have the best intervention at the right time? We're not looking at just one intervention at this time and we want that intervention to win. We're looking at all the interventions we could do over time. That being said, we could cannibalize each other. So the basic point is there are real choices to make to say if this really succeeded, it might cannibalize that. At the same time, if we take that patient view, we take that physician view, we just care about treating the whole care continuum, we think ultimately we all win.
No, I think that's a great question, because if you invented a minimally invasive technique that made spine surgeons do less spine surgery, and you're a spine surgery company, that's a little bit of a complicated thing. I'm going to ask the same question to each of you. This time, starting with Dave going down that way. So Malik, you're going to have the toughest answer this time. But I'm going to have Dawood comment on your answer, and you can say whatever you want. But here's my question. In the business of interventional spine and pain, which is where we are here in this discussion, what in the last decade, what have we done poorly? And maybe 30 seconds to a minute on that. And then what have we done well? So give me one thing we've done. And the reason I want to ask you that is because what we've done poorly is what we need to focus on in the future, right? So what we've done poorly as a group, not your individual companies, but as a group, and what have we done well as a group? So Dave, you get the first go at that.
So maybe I'll start with that same category we just talked about, which is on the minimally invasive spine side. I think there's a poorly and well there. I think on the well side, there's an explosion of interest and an explosion of new techniques and opportunities. And I think, I'll call it poorly, but it's really developing, is the evidence is still building. So there was a lot of discussion in the panel today. How do we create the evidence that convinces, for example, our surgeon colleagues that are also treating these patients at times that these minimally invasive techniques have just as good or better outcomes. So I think the opportunity is significant, and then how do we build the evidence to scale it?
Dawood, how do you do?
I think it shines through that he works for Medtronic. He knows how to give a very fair and balanced answer.
I'm not sure what that means, but go ahead.
So I mean, I've been in this business since 2004, so 17 years, and I would say initially when I was in this business, what we did is the companies were focused on features and benefits that didn't necessarily add benefit to the patient. And I think over the last 5 to 8 years, there's been more of a focus on the patient. That the therapies that are coming out are backed by evidence. They're studied once they get into the market, and we've shown the longevity we've really started to show the longevity and success of the therapy, and and really the patients become the center of development in neuromodulation and pain in general. So I think the focus from feature and benefits initially and now was not ideal. Now the focus on the patients is really helping.
Great.
A+.
A couple things. I think we've done a relatively poor job, but an increasingly better job of managing the entire continuum of care and making sure that we're feeding patients through the funnel, number one. Number two, I think, I've been doing this, Keith said since a long time ago, but I started in 1995 with Medtronic. And I don't think anybody's really cracked the nut on how to really enter the market and drive referrals from people like orthopedic surgeons and private practice and APPs and so on. So I think there's a whole lot of market to be expanded yet that really hasn't been penetrated because the word isn't getting out there effectively about how effective these interventions really are.
Great answer.
I'll start with poorly. We've got a RAC auditor on spinal cord stimulation and prior authorization going on. We have a poor reputation among our colleagues in other specialties. We're blamed for one of the worst travesties of the last 20 years in opioid addiction. Probably could have done a little better in all of those areas, right?
I may be too depressed now to carry on their conversation.
On the good side, we're making better gadgets, making better devices. I think we're defining problems better. I think we are getting better at understanding where those referrals lie and how to get them to come in. So I think we've made progress, but I think that, like I say, the challenge is, and Keith said this in a different way, but it's not just about technology, right, which is what excites a lot of us. It's really the application of that, the support of that, integrating it into the whole patient experience.
David's behaving himself, so I'm giving him an A as well. Well, that was an easy A then. No, I like the question, and I love the commentary from everyone. I think when you look at it, industry has done a fantastic job of partnering with societies and physicians, and there's a lot more clinical data. There's more to go, for sure, but if we look at 10 years ago, if we look at 15 years ago, not much clinical data. And so I love the fact it takes a big investment, and I like that industry is demanding that of themselves. That's only good for patients at the end of the day. And it gives credibility to what you said, David, which is it gives credibility to the industry when you have good data with payers and everything else. When I look at what I think we have not done well, is I do think we come up with, together, physicians, clinical data, industry, come up with great devices, services, and technologies that meet the needs of the patients. I think from an industry point of view, we do a very, very poor job of really getting into the matter of how to incorporate that into a practice. And we look at utilization as an example, the stickiness or however we want to think of it, and we can see one physician, they'll do 100 a year, and another physician will get good outcomes and they'll do 2 or 3 a year. Whose responsibility is that? Ultimately incorporating, and I agree with what you said, we've not perfected on how to take a great technology that's safe, efficacious, and durable and incorporate that in the day-to-day practice anywhere across the globe. We just haven't done it. And so there's sensationalism where people say, well, this physician has done 200, so you should too. Well, the reality is that physician might not know how to incorporate that into their practice or how to pick a patient or the referrals or
commenting. And so from an industry point of view, we have to be much, much better at not only addressing that, but preparing our customers so that they can treat those patients, because I desperately think the level of empathy, they care about their patients. All the physicians I've ever known care about their patients. We in industry care about patients. So we have to do a better job and be more responsible in building and developing better businesses.
Great answer, and nice black sports coat, so A.
Okay. I think that from where we were about 10, 15, or 20 years ago, even if you look at SCS, and I think Keith said it, that we moved away from features to starting to really combine with clinical outcomes, and the technology innovation is really accelerated. And you can see that in the last 5 years, and hopefully we're still very, very early in where the innovation is taking place, and we have a long way to go in understanding and how to really take advantage of understanding the nervous system and the neuromodulation as a field, plus adding other interventions to really create a category of how do you treat the patient. And that's really the positive. That acceleration has taken place. On the other side, I think the biggest challenge is the pain is the fifth vital sign, but our best biomarker is asking the patient, how do you feel? And to me, I think there's an opportunity here on how do we really get to more standardization of how to treat the patient, because ideally you would want to see interventional pain physician in practice to be the first stop for the patients to come. Right now, the patient's outcomes depend on who they end up seeing first, whether it's a chiropractor, or the surgeon, or interventional pain, or a GP. And I think that is where the opportunity is to get better.
Yeah, I think it may have been Chris Bovenet, but someone today said we should become the primary care of pain. And I think that's pretty interesting. I never heard that comment before. We have time for one more question. So we'll be kind of rapid fire. Dawood will ask the question that's going to be very complicated.
That was a great answer, Malik. So my question again is going to go starting from Malik and going all the way back. So I think those of us, like, I'll make the analogy as physicians, we all kind of believe that competition is a good thing. Like, I'll make the analogy if I'm a neurosurgeon or a pain doctor and there's 2 or 3 in my community that are doing a good job, we all feel that's a good thing. But then if there was like 20 interventional pain docs in that same region around me, it starts to get a little crowded. You know, when I was a fellow 10 years ago, there was really, we called it like the big 3 companies. You know, there was, what is now Abbott now, Medtronic, and Boston Scientific. But now it's getting more crowded. Nevro's now become kind of an established company. There's way more other companies. SPR is here on this panel with us. So how do you guys, honestly, what are some of the pros and the cons from each of your guys' perspective of this, increased entrance into the market in the interventional pain neuromodulation space?
And I won't comment on your answer, so it's just a rapid fire down the line.
Okay. Dowd forgot to give me the grade, so I was just still waiting. Okay, thank you. So I think that, to me, that's where innovation comes. So you really need to have the startups. You need to have the disruption taking place. You need to have different approaches. That's really the most important thing. Otherwise, the field is not going to move forward, and the bigger players may just get complacent. So that's really important for the growth for the field. In terms of where the focus and how do we feel, I think that we'd really like to see the focus more on the patient, what problem you're trying to solve first, and second is the outcomes, and then the technology comes after. So if the problem solving is much clearer, the data is really solid, then everything else can be taken care of or solved much easier, and the complexity goes away.
Thank you. So I would say I love the competition because that attracts the very best, and the prize becomes bigger, and everybody works harder. I won't name the name of the company, but I was part of a strategic assessment, and what the data actually shows for a typical patient is they have a 1 in 25% chance of getting access to the correct physician. That's scary. So there's a long way to go to improve the system, and I know all these companies can do it, so more the merrier.
Yeah, so I think the challenge is really understanding that the market in general for pain, for neuromodulation, is way underpenetrated. And it's just a small percentage of it. So there's a room for new technologies, and I'd agree that brand new startup companies are certainly the birthplace of great ideas and great technology. It's challenging to come out, having been with Nevro when we went public. It's challenging to come out, especially from large incumbents, and translate into meaningful market share that's sustainable. And very often the best path for many of the startup companies may be to join forces, right? Whether it's an acquisition or whatever other type of thing. So those good ideas can actually be developed and delivered out there to these patients that do need these important therapies. Other times companies develop products in-house, right? And there are all the reasons that I think everyone can understand why that's sometimes a good idea, a very good idea. So we need to identify then those markets that are underpenetrated, which in our field is most of them, for which there are no good alternative treatments, for which device technology can be compellingly delivered, with great evidence. So I think that's where we are. And if that comes in a startup company, great. I think they'll find ways to deliver that and work with existing companies or find their niche in the market to build and better it.
I agree with Malik. I think competition drives innovation, excellence, and really pushes the field forward. I was at Medtronic at a time where there really wasn't a competitor, and it wasn't until then ANS came on board and really pushed us. Then I left to go to Advanced Bionics. But I think until you start to see all these companies come into play, we don't push each other. And that's a problem. In the particular space we're in, which is PNS, I call the other companies in the space my co-collaborators. There's so much market here to be had as we build this space that I don't look at them as competitors. I think there's a real opportunity for synergy as some of these companies figure out how they can complement each other. And so I think you have to look at the competition really sincerely and say, are you really my competitor or are you really a co-collaborator? And I think all of it drives what we all want, which is better care for patients and a real full continuum for you to offer a great palette.
Yeah, I think I agree with everybody. Competition is good, and what I said earlier was the features and benefits to evidence to thinking about the patient. All that was driven by competition in this space, whether it was Medtronic, ANS, Boston Scientific, and then Nevro. So I believe competition is good. I think it drives innovation. I think it drives clinical evidence. If you look at the whole interventional pain market today, the spotlight on opioids has really kind of changed the space from a focus on neuropathic pain to now there's a focus on neuropathic pain and nociceptive pain, and you can see with all the companies that are out there today, it's driving massive competition, and it's only better for the patient long term.
Yeah, and maybe to double click on the point of competition driving innovation, you can see how it created an interest in that area. Take Nevro with therapy innovation, and now each of the major companies have therapy innovation in their waveforms and their algorithms. You can take Saluda with closed loop, and now we're focused on closed loop. And candidly, I think it's going to be a solution that each of the companies will look at more carefully. So it's not just driving innovation, but it's driving a whole focus area. But I'll also say that if you look at it from, if you're not bringing something differentiating, you could exit too. And we've certainly seen companies that have come and gone because they didn't really bring something differentiating.
Great. Well, great job, everyone. That's it for this panel. Thank you all very much. We have one panel left, so I encourage you to stay for the next panel. And we'll bring those folks up. I will remind everyone we got the 5K run. It's for charity. So you get a nice shirt. We're running or walking. You can walk the race if you want to. And it'll start at 5:30 after this ends. So come on up for our next panel. We have a great panel to bring up to the chairs here. All right, here we go.
Congratulations. John Wood, good to see you. How are you? What's up, Travis? Eric? Jason? Bob? Good to see you. Juan Pablo? Good to see you.
Hey, how are you?
Very
See you
nice
again.
to see you guys. Yes, thank you for having me. Sean?
I think we have to get the two hottest chairs, aren't we?
Yeah.
Yeah. Sean, what we did last time, we brought one, bring one over there and one over here. That's perfect. All right. All right, so it's our last panel of the day. We have 30 minutes. And, this is a little different perspective because it's a different phases of where we were in the last session. So I'm going to give Dawood the first question. Dawood.
So I think probably a better place to start here because you guys are a little different phases, as Tim mentioned. Just introduce yourself because probably a lot of the people here do not know you and which companies you work for and your background. So Juan Pablo, would you start, please?
Sure, thanks. Juan Pablo Mas. I'm with a fund, venture capital fund called Action Potential Venture Capital. We're a subsidiary of GlaxoSmithKline and invest largely in the space of bioelectronic medicines, advanced neuromodulation across a variety of disease states and indications.
Jim Sherman, CEO of Saluda Medical. We're an Australian private company. We are early stage, approved in Europe, and doing clinical trials in Australia and the US, finishing up our PMA study. And happy to be here and looking forward to the discussion. Thank you.
Yeah, thank you. My name is Travis Greenhall. I'm CEO and co-founder of Surgentech. We're a medical device company based out of Boca Raton, Florida. We specialize in minimally invasive spine solutions and synthetic bone graft technologies. We have a really nice crossover in products between the interventional pain community, neurosurgeons, orthopedic surgeons, and even over into the foot and ankle space a little bit. Our goal is to make spine surgery less invasive with better efficacy. And we're very excited to be into this space. It's growing rapidly, and we're happy to be part of it, developing products to help the interventional pain community treat their patients.
Eric Wickams, I'm President and CEO of Vertos Medical, the makers of the mild procedure. We're one of the early pioneers for minimally invasive surgery for interventional space.
Jason Hannon, I'm the CEO of Mainstay Medical. We make the Reactivate device, a restorative neurostimulator for back pain.
Bob Compton, I'm one of the co-founders and director of CornerLock, minimally invasive SI joint fusion. Come from a background of nearly, I hate to say, 30 years in spine and orthopedics. I've only been in interventional pain since 2017. And it's really a great market to be in. The relationships that I've built with you all have been fantastic, and really looking forward to the future as we move forward.
Hey everybody, Sean Leneve, CEO of Pain Tech. We make an SI joint fusion product called Link, and thanks to everybody for sticking around. I know a lot of you would rather be at the pool, but thanks for listening to us. Pain Tech, I got into interventional pain in 2013 or so, and really excited about this space. What you guys are doing out there is phenomenal in treating patients with these minimally invasive technologies, including ours. So thanks.
Yeah, what a great panel. So we have a lot of talented people here. We don't have a whole lot of time. That's the beauty and the bad problem with panels is that you have a lot of people and you want to get their opinion. But Juan Pablo, I think I'm going to ask you a quick question, and then we'll have Dalwood ask a follow-up question to everyone else. You've invested in a lot of companies. You and I've known each other for a while now. You've done great work and investment in the companies. What is the critical factor? I just want you to give me one factor when you decide to make an investment in a company that's on their way to either an IPO or on their way to going to get acquired by someone else. If you had to say there's one factor that this is it, what's the factor?
Yeah, well, in a nutshell, I think it's outcomes. It's can you deliver the benefit that we all hope our companies have promised to deliver, and oftentimes we don't have those data before we invest. So when we're investing earlier stage, we really look for great technology and largely platform technology that can deliver across more than just one indication. So ultimately outcomes, but when we don't have the benefit of that, it's focus on innovation and technology.
Perfect. So Dalwood, you want us to follow up to everyone else?
Yeah. So on that other end, you guys are all, I would say, early stage companies. What has been, at least in your personal mission with the company you're working with right now, the biggest challenge to kind of get your product from, a concept all the way down to commercialization?
I think the biggest one is, you can take a great concept, you can take a great idea, an invention, or fill an unmet need, but getting it from concept to commercial is is a massive undertaking. And so I'll just summarize by saying, it's an execution of milestones. And, there are disruptors, there are individuals who are disruptors, there are leaders, there are companies that are leaders. There are people that can execute. In a small company, in a small, very small incubator company, you don't need all three. But when you get to be a commercial company and you get post that regulatory stage to commercial, you need all three. And it really comes down to execution. And it's the issue that we all have to overcome, because there are so many innovative new technologies out there. Really getting from concept to commercial is a massive effort, like the Army, of execution. So I think that's the biggest challenge we see on small company on our end.
Yeah, I think there's a lot of trials and tribulations, regardless of the size of the company. We're fortunate to have an amazing team that helps us navigate the space. I mean, over the past 10 years, I can remember so many times of we've had setbacks and times where we actually had to pull products, halfway through, once we've received intellectual property and production, and actually had to shelve it when navigation came out. But I think the biggest thing is to make sure that you have all of your patents in line, all of your intellectual property. You have your production, your manufacturing. I mean, a lot of times companies wait until the very end and scramble at the end when they're looking at mass productions, but really you've got to find good OEM partners to make sure that they can mass produce your products. And it's something to think about from the beginning, because strategically it takes quite a bit of time.
Well, I would be delusional if I didn't say payer access based on the history of the mild procedure, but that's probably not an interesting answer. So I'm going to echo some of the things that were said in this panel, also by Mike Enzing in the previous one, which is one of the biggest challenges is the integration of new therapies into a practice. And what do I mean by integration? If you have something really new and interesting, it is probably pretty easy and straightforward to get a physician to do your procedure. But the real magic happens, are they still doing the procedure 1, 2, 3 years down the road? That takes a lot of execution, a lot of thought, a lot of collaboration, and building a company. That's the hard part.
I would say if you're transitioning from research, so our company has spent 12 years in research, primarily clinical research, transitioning that into marketing, into commercialization, the biggest thing is matching the right patient to the therapy. This is the greatest time, I think, possible to be an interventional pain physician, with the explosion of tools at your disposal, new techniques, new procedures. Like, our ability to partner with physicians and match that up is what is a struggle we've been living through the last couple of years. That's where we can partner best with physicians. I ran a spine company before this, and it's much easier in spine because there's a history of who needs a fusion, who doesn't, and then you watch explosion of indications. Our job is to try and figure that out. That's the biggest challenge we face.
Yeah, I think in terms of from concept to commercialization, we had a fairly easy route. Having a bone graft for minimally invasive SI joint fusion, the barrier to entry is a little bit less than it is for a 510K. There's a FDA process, but so that was fairly easy for us. I think probably the biggest challenge for us has been, as we're moving forward and coming into this year, dealing with some of the opposition to the coding. Some of the spine-related companies in our space, are really pushing for trying to keep that coding for themselves. And so, I think one of the big challenges has been realizing, and I think Mark Stoltz commented on this in the previous segment, that we have to recognize that our competitors are not necessarily our competitors. There's a huge opportunity in SI joint fusion. There's so many unaddressed SI joint potential fusions out there. Potential. I mean, I think currently in 2020 they estimated about $150 million was the market. And the opportunity is actually about 10 times that. We have to realize that our competitors, like Sean sitting next to me, are not really our competitors. There's so much opportunity out there. And Sean and I actually get on the phone probably once a month at least and talk about data and outcomes and what's the best thing for the patients, what's the best thing for interventional pain and the physicians, so that we can maintain this coding for you all to help your patients moving into the future. So I think that's been our biggest challenge so far.
Yeah, I think that's really well said, Bob. You know, starting a company, we have all the same challenges that anybody else would have in financial capital, human capital. Everything takes twice as long as you think it'll take, but between CornerLock and PainTech, we have been very fortunate in that our path to commercialization has been faster, but then it puts a new responsibility or accountability on us to make sure that we have a sustainable therapy. And so the reason Bob and I work fairly close together is for the betterment of this space, to make sure we can take care of patients and make sure that folks like you have this therapy available to you for years to come. So we're focused on things like producing the evidence and the data and things of that nature. So where the panel before us talked about industry plowing money into, and I heard the word millions multiple times, when you're a small company, you don't always have that luxury. So we do what we can with what we have. But I would say that's a fairly big challenge.
All right, so the next question, we're doing well. We got to run about 15 minutes away, so everybody warmed up. But I think the next question is very important, and that's intellectual property. And Juan Pablo, you mentioned it, so I'm going to make you last this time because I want your impression of what they say, because you don't want to invest in a company that can't maintain their own intellectual property. Here's the question: how big a problem is it, and does it matter? Can you outcompete everyone if there is no IP? We'll start with Sean and go down the line. How important is IP, and can you compete if there is an IP?
What is intellectual property?
I'm
just kidding. You know, intellectual property is the key to building a moat around any business, right? So if folks can go straight into the market and copy all the work you've done, then you're in a really bad spot. So certainly for investors and certainly to scale your company, you have to be able to protect the work you've done. For us, it's a little bit different. It's a little bit more difficult, in fact, when we're talking about human tissue. But there are things you can protect, and we work closely with our IP attorneys to find those angles, to find things that are unique and novel to the way we approach, clinically solving this pathology, this disease state for patients, and we've been successful doing that. So it's not easy, and again, it's not something that everybody, at least in our space, is focused on, but it is incredibly important if you want to create a sustainable company, for sure.
Bob?
Yeah, I think that's a great answer, and I would, and Keith mentioned earlier in the previous segment that when it comes to acquisitions for the larger companies, that's something they're very keyed into, is intellectual property. So that's one of the very first things we set out to ensure, was that we have a good patent around CornerLock, and our next generation also, we have some IP being developed around that. And it's good to have a good, competent patent attorney to understand, patent language is a whole another language that I pretend to understand it when I'm meeting with my attorney, but I really don't. And I mean, the way that you have to state things and the way that you place your claims and name them out and layer them out are very important. So it's important to get a very competent and intelligent patent attorney or group of attorneys to help you with that.
I think IP is the importance of it's directly proportional to the novelty of what you've built. Our therapy is a novel approach. It's a novel mechanism of action. Incredibly important that we own the IP. And because of that, it's not IP to a specific feature or function. Our IP is a mechanism of action. If it's that novel, I think you have to own it. IP doesn't stop at a patent, in my view. IP is, what's your regulatory strategy? Could you set it up in a way that anyone who comes after you has to do the same thing? If it's multi-year, you get multi-year protection if that's the case. If you're first to market, it's how you bring it to market, the support structure you put in place, the clinical data you gather. Those are all the picket fence, in my mind, you build around your therapy, not just patents. I think it's just more than that.
Yeah, I think it depends on the stage of the company that you're in. IP is always important, but having raised money in multiple rounds during multiple phases of the company, IP is always the start in terms of that's important. Do you have it? Payer access. If you have special payer access, incredibly important, especially if you're a commercialized company. And then last, and it was alluded to before, is do you have good quality clinical evidence?
Yeah, I think, IP is extremely important. So over the past 10 years, unfortunately, I've had to learn the patent language that you alluded to and spent a lot of money, I'm sure, as everybody else. I think one of the biggest things to bring up is enforceability, and it's becoming more difficult. So you're spending a lot of money on intellectual property, and you're forced to. But actually enforcing it becomes more difficult. That's the way the system is set up. So I do believe that it's essential, and I do believe that you have to continue to build out your intellectual patent portfolio around your products. It's very time consuming, and hopefully that the laws and rules and regulations will change soon.
Agreed, it's critical. It's almost table stakes now that you've got a strong IP portfolio, especially with a breakthrough technology. You have to evergreen it. You can't just settle and say, we've got 4 patents, we've got 17 years on this, we're going to be fine. You have to keep innovating and pushing forward. You know the competition well, especially if you have a breakthrough product. They're going to try to find opportunities to innovate around you. But I think also critical is the know-how, that intellectual know-how inside. It's the Coca-Cola secret sauce. And that comes from talent, that comes from working with the right clinical collaborators or the best in the field, and innovating with your clinical collaborators. That could lead to an IP invention, or it just could lead to another new, different way, a different protocol, a different approach that is uniquely yours, built on your technology. So I think it's a combination of things. I think as a small company these days, companies spend a ton of money on IP protection. It's a different world than it was 20 years ago, but you can't forget the other pieces as well.
So Juan Pablo, your perspective on that, then Dawood will ask the last question.
Sure. Yeah, I mean, I think everything said here, was accurate. We spend a lot of time on intellectual property diligence when we're investing in a new company. Oftentimes you learn that companies have invested in it, prioritized it, make it a regular topic of conversation. I think we always guide our companies to not just invest in continuing the relevance of their IP and filing strategy, but also auditing themselves by virtue of running freedom to operate studies with outside counsel and beat up their own portfolio and say, what do we need to do better? What should we go out and acquire if we need to acquire something that somebody else has? What can we license in and so forth? And it translates to value in the eyes of potential acquirers as well as they evaluate a new target potential acquisition. So, from all those perspectives, especially in medical devices, it's extremely important. I think there are new models, new business models that make the importance of IP perhaps less crucial in certain cases. You can have competitive advantage and moats by the virtue of generating significant data, and that is in lieu of, you may maintain a competitive advantage by having those proprietary data sets. Another is just speed to market, right? And if you are effectively the only one in a space, then, even if you don't have IP, you're gonna have the potential to make real market gains. So across those, dimensions, we think a lot about it, and we've walked away from more than one deal at essentially the 11th hour because we uncover something in IP, and it can kill a deal.
That's great insight. So I'm going to ask Juan Pablo the first question, and then everyone's going to have a different take on it. So IP is very important. Probably another thing, the second thing people ask you about is how good is the evidence for your product? So, and it seems like the commercial payers and CMS is getting exceedingly more challenging. And during the early sessions, I asked a lot of the panelists, what they want to see about a therapy, and they all asked for the sun and the moon. They asked for a level 1 randomized clinical control trial, very high level evidence. And I know, Juan Pablo, that's pretty expensive, especially when a therapy is maybe pre-market and you have to write a blank check. What do you look for when, one of these guys is designing a study, because you've kind of successfully exited a lot of these investments. When you look at a clinical trial design, what are things that you look like, yeah, this is what we need to do, and I'll write you the blank check for this one?
Yeah, well, GSK has a large balance sheet from which we invest, but still haven't written a blank check. So we usually put a number at the end of it to make sure that the company does what they need to. But I get your point. I think the importance of evidence is paramount. My background prior to being in neuromodulation was cardiology, and spent a variety of years at Medtronic in interventional cardiology and so forth. And I believe that it's like anything else. It's like your education, your experience. Nobody can take it away from you. If you generate rigorous level 1 evidence, that is a huge asset. But to your point, expensive for small companies to generate that. I think a couple things that we look for in earlier stage companies that haven't yet run those trials, and there's a benefit in pain in the sense that you have trial leads, two-week trials that allow a novel therapy to come in and evaluate some degree of efficacy short term, but some degree of efficacy before you invest large dollars in developing a proprietary implant or IPG. And I think it's part of why a lot of companies early stage companies gravitate towards pain and other areas like urinary incontinence, because of the ability to test something before they have to raise a lot of dilutive capital. The next thing we look for are teams that have a clinical trial strategy that leads into rigorous pivotal trial data by virtue of running an RCT in their phase 2 study, or at least some control type study that they can predict or foreshadow what a pivotal trial might look like. And then the third element is just the durability of effect, of the length of those follow-up periods for those studies, because to your point, payers care a whole lot about how does this look long term. So those are kind of the ways that we evaluate it.
Jim, yeah, you care to kind of comment on that as a CEO of a company, when your clinical team is, postulating what studies they're going to design? How do you look at it as a CEO?
Well, when I speak to investors, there's really three things that they are focused on when deciding whether to invest or not. One is it a large addressable market with an unmet need? Number two, is there established reimbursement, or is it a reimbursement opportunity? And then number three, how's the clinical evidence? And earlier stage, it's not as critical, but later stage, it's absolutely required, especially if you're doing something different with a novel approach. If you're a Me Too and you're coming out with something that might have a low bar through a 510K, not requiring a clinical trial, and you're going to win by better pricing, for instance, then the clinical data is not as critical. But if you're really coming into a market where you're establishing a new way of doing things and wanting to establish a new therapy, then clinical data is absolutely critical. And many will say the FDA is the bar. Well, we believe the FDA just is the entry in. It's really the clinical community. You have to believe that this clinical data is foundationally solid and is reproducible in the commercial arena. We've all seen, and I mean commercial, I mean post-clinical and post-FDA approval. Real-world data is what Medicare is looking at now. So establishing really strong clinical data up front, that it's reproducible, believable, and the reproducible side post-approval will give the clinicians confidence that this is a therapy worth using, and I think that's a ticket to success.
Great job. Travis?
So we're really, I guess, set up, early age company for preclinical testing. So as far as the prospective studies, that's something that we're looking at in the future, some of our future products. But even just to get through the 510K process or other approval processes, we are set up for preclinical testing and kind of going above and beyond what most companies do. And I think initially it's extremely costly and it takes more time, but that data helps when you get to the market, create confidence from the physicians, and also helps navigate the FDA arena. So while our sights are set on prospective data, we're going to be harvesting retrospective data soon, and we're really focused on preclinical studies.
Great.
I don't know. There you go. I actually completely agree with Jim and his characterization of what's important as you start getting larger and larger in the company. And on the topic of clinical data, we are a massive believer in clinical data. We've done 14 studies now. And each study has a different purpose. Some of them are to really nail down the patient that you're going after. Others are to convince payers. Others are to convince physicians. So you have multiple stakeholders looking at this. So the way I always talk about clinical data is picture a house. So the IP discussion that we had previously is the foundation of your house. If you're innovative, and that's what I'm talking about right now, innovative therapies, you have to start with a solid foundation, and that's IP. Clinical data is the rebar on the house. That's what's going to keep that house standing for a very, very long period of time. And so I think the investment in clinicals is extremely important, and the nature of what you need to look at really depends on the stakeholder that you're looking at, whether it's the physician, payers, patients. We now are doing a motion study. A big reason for that is to have data that referring physicians and patients can easily digest, as opposed to the patient-reported outcomes like ODI and stuff like that they don't understand.
Jason?
I would add that clinical data is a flip side of cost, investment, time, and I think it's important early on to decide with your therapy, are you penetrating a market? Are you creating a market? If you're creating a market, you better have the wherewithal to invest to generate the data, because you have so many different audiences you have to please, yet you got to get over the FDA, the regulatory burden. That same data doesn't compel an insurer to pay for your therapy. It may not compel clinicians that it's going to be reproducible in their hands. So if you're creating a market, it is absolutely foundational, great point, and you better just continue to invest because you have to serve so many different audiences. Maybe it's a randomized study, maybe it's a study to compel payers, maybe it's a study that is multiple studies and real-world evidence that clinicians want to see it can reproduce. It's never ending, but it's a requirement.
Well, a lot of great answers. They stole all my answers. Yeah, no,
It's harder on this end.
Right? Yeah, when we got into the market at the end of 2017, one of our top priorities was to start collecting data as early as possible. We've got a couple different registries going on. We are conducting an RCT currently, which is ongoing, and it's been a big budget item for us, but we're committed to not just proving out that our technology is working as well as we had hoped, but also the payer question. In this fight that we're having on the code, that's going to be really be the answer. And fortunately, we've done a good job of capturing a lot of data. We're going to be presenting a paper on close to 250 patients to a journal to be able to be used in that fight. The RCT is a ways out still, but we're plugging away and keeping moving on it. It's a huge priority for us.
Perfect.
Yeah, all great comments. And Jim kind of mentioned this when you're talking to investors or you're talking to folks on the outside. The question I get asked all the time is, what's your regulatory strategy and what's the reimbursement strategy? And it changes, right? And it changes as soon as you think you've cleared one hurdle, another one jumps in front of you. And what happens in early stage companies for us is, we're payers, and especially commercial payers, may be silent on our procedure, but then you develop some level of commercial success and you pop up on the radar. And it's almost punitive what they do to us in requiring an RCT with 5 years worth of outcomes. So not only do you have to enroll an RCT, but then you've got to follow these patients for 5 years before that payer will acknowledge you and classify you as medically necessary. And so what that does in my mind is it really withholds that procedure from patients and from being in your armamentarium as a physician. And it's unfortunate, but it's something that we all know we have to deal with. So the faster you can get started on that road to producing that clinical data, the better.
Very good. Yeah. Great job, everybody. May you guys all hit your IPOs and be as successful as Fig Scrubs, who's worth about $5 billion now. So good job.
So 5:30, the Americana Lawn, which is past the pool to the left for the 5K walk run. There's a beer garden at the end. So if you don't want to run, just donate to charity and have a beer. We're happy with that. Great job, everybody.